Okay, guys, welcome to the discussion. And the main agenda behind this video is to talk about tachyarrhythmias. But before I do that, I need to explain to you some baseline information with respect to the waves of the ECG. And what you can see is the graph paper on which the ECG would be recorded. One and the first thing that you need to remember is that the duration of this one small square would be approximately 0.04 seconds. But I personally would suggest you to remember this in a round figure of 40 milliseconds. And you can also see that one large square of the ECG will be having these five chotu sota small square, and as far as the depth of the small square is concerned, that would be 1 millimeter. Now with this, you can also check out the normal waves, that is the PQRS waves. We'll talk about the reasons behind each one of them, but then you can see a small positive deflection that is present after the T wave. And this again was a question in the paper, that why do you get this wave and what is it called? Then the answer would be given as U wave. And well, why is it occurring? That I'll be explaining to you in like about a minute from now. Now, as far as the details of each one of these waves is concerned, just to see that if you know about ECG without checking out your notes, can you tell me what is going to be the amplitude of the P wave? The vertical height of the P wave in a normal person should be less than how much? You see, P wave genesis is from the SA node. The SA node is going to fire, it's going to send the current to the left atria, then to the right atria. So ultimately, we will be having is a atrial depolarization, which is responsible for generation of the P wave. And as far as the vertical amplitude is concerned, this would be less than 2.5 millimeter. Now, why is that important for you to know this is because I'll be teaching you conditions where the vertical height will be more than this. I'll be saying terms like P pulmonale, or for that matter of fact, you should be knowing what is the duration of the P wave. Duration, I mean like the entire breadth of it. The duration should be less than 120 milliseconds. And why you should know this is because of the fact that I'll be teaching you terms where the duration is more than 120 milliseconds, but I'll just say it verbally at the moment, that is P mitral. So those are like very classical kind of questions that are asked in the exam, and they're very straightforward as well and easy to score. You can also see that if the duration of one small square would be 40 milliseconds, so mathematically speaking, like 120 divided by 40, the P wave of yours and mine will fit into, horizontally speaking, it will fit into less than 3 small squares, and vertically speaking, it will fit into less than 2.5 millimeter height. P wave is always an upright wave, but you will also notice that it will be negative as far as lead number AVR is concerned. In fact, when you check out the recording in lead number AVR, you'll always notice that two of the positive waves or upright waves in the ECG, that is P and T. Normally, like P is also upright, T is also upright, but this what I'm telling you is perfectly normal, that in a normal person's ECG, you will always notice P wave to be upside down and T wave to be upside down in lead number AVR. And when it comes to lead number V1, for AVR, I was saying it is going to be negative or upside down. And for the V1 part, I'm saying it is biphasic. What I mean by biphasic is that some part, that is right atrial depolarization, would be above the isoelectric line, and some part, that is the left atrial depolarization, would be present inferiorly, that is below the isoelectric line. So these are like normal data that I've currently explained to you, and then in a couple of minutes from now, the abnormalities will also be introduced. Now, as far as the PR interval is concerned, the name is PR interval, but it is not from the P wave to the R wave. You know this from your basic sciences classes as well, that the duration of the P wave is less than 120 milliseconds. And when it comes to PR interval, guys, if he says PR interval is from, then your answer is from the starting of the P to the starting of the Q wave. What does it signify? Well, it signifies AV nodal conduction. So that is okay when the current is going down from the SA node towards the ventricle. So it has to navigate via the AV node. And you also know that AV node is having innervation of the vagus nerve. So there will always be some delay present. In fact, at this moment, I also want to add from the physiology domain that AV node is actually called as a gatekeeper of the heart. You can call it gatekeeper, you can call it goalkeeper, because it is having vagus nerve, so it will cause a decremental property. And because of this decremental property, about 0.1 seconds I can say is wasted before the current would be going down. That 0.1 second, I said wasted in a sense that it's like a natural speed breaker in the heart, and that is trying to control the speed by which the impulses would be going down. So vagus nerve is like I would say a brakes in the heart. It innervates the SA node, but it innervates the AV node as well. So they're like double check systems present, so that you can keep the heart rate under check. And as I said, the PR interval, the name is PR interval, but it is not from the P, starting of P to the R wave, and it is the starting of the Q wave. Important aspect to be remembered also is that PR interval is always inversely related to heart rate. So subsequently, when I'll be saying tachycardia, in all questions on tachycardia, I'll be saying the word short PR interval. Every time I'm going to describe bradycardia, like heart blocks, I'll be saying like a prolonged PR interval. Now the question in your mind would be like, what is normal? So normal PR interval is 120 to 200 milliseconds. And what I need to explain to you subsequently are conditions where there would be short PR or where there would be a prolonged PR. Obviously, I give you a hint there, right? I mean, conditions related to tachycardia would be having is a short PR, and bradycardia conditions or heart blocks would be having presence of a prolonged PR interval, but more technical details will be added subsequently. Now, once we're done with the P wave and the PR interval, we next talk about the Q wave. And this is like a error that I see, that the moment we read about Q wave, people tend to rush into the answer and answer it as ventricular depolarization. Guys, ventricular depolarization is the answer that you need to give for the QRS complex and not for the Q wave. So if he says, why do you have as a generation of Q wave? Then your answer is simple, septal activation. You see, we have an interventricular septum. This septum gets activated, and therefore we'll get this Q wave, and it is always written the chota alphabet Q. It's like a small negative deflection. The depth of this is less than 25 millimeter of the following R wave, but generally speaking, you will notice that Q wave will always be fitting into one small square. Like I said, there is like one big square in the ECG. And then in that one big square, there would be like 5 small squares, which are just symbolically drawn. So I just want to say that the Q wave in a normal person's ECG will fit horizontally and vertically into one small square. That's just an average way, because in exam, you can't calculate by percentage. No, I mean, there would be no ruler or scale that would be available before you. So how do you pick up whether Q wave is abnormal or not is what I say next, that if the Q wave is spilling out of this one chota small square, either horizontally or vertically. As I said, Q wave normally fits into one small square horizontally as well as vertically. But if the Q wave is going to spill out of this small square, either horizontally or vertically, then we will say the word capital Q wave. Now, which are those medical conditions where that capital Q wave would be present is what I'm going to teach you subsequently, like a minute or 2 minutes down the line. But I just wanted to explain to you the nomenclature, that in a normal person like you and me, we say chota Q wave. But in some conditions like myocardial infarction, in fact, I could not stop myself from saying that, MI is like one condition where you get these capital Q waves, which indicate cell death. And I'll be telling you much more beyond this when I go a little forwards. Now, as far as QRS complex is concerned, it's responsible. I mean, the cause behind that is ventricular depolarization, and he will ask you the duration of it. The normal duration of the QRS complex is in a range of 80 to 100 milliseconds. That 80 to 100 milliseconds would be in a range of about 2 to 2.5 small squares. So I can say that I'll be subsequently describing conditions to you like narrow QRS tachycardia. So when I say the word narrow QRS, it implies QRS duration would be less than 80 milliseconds. And if I say broad complex, then it's going to be like more than 100 going up to 120, 140 as well. So what you need to check out is the number of the small squares, right? I mean, you will have to physically count the number of squares. Then if you have to say narrow, that would be like one small square, or like less than 2 would be 1. So like QRS all will fit in one small square. On the other hand, when it comes to conditions like ventricular tachycardia, we'll be having is like a broad or a wide QRS complex is present. Now, having said that, I want to next focus on what is called as the QT interval. So I'll just put some pointers here. Just a couple of minutes ago, what I did was I put pointers like this, and I said that the starting of the P and then the starting of the Q wave is what is called as the PR interval. So let's just put that on record. And now what I want to say is that the distance between the 2 points that I'm creating now before you, that would be the starting of the Q and the end of the T wave. These 2 pointers that I put, the red one and then subsequently the second red one and then subsequently the green one, this is what is called as QT interval. So QT interval starts from the Q and ends at the T wave. And what you can see from this nomenclature is that QT is including QRS, which is ventricular depolarization. It is also including the T wave. T wave is responsible for ventricular repolarization. So one of the very common things that you always tend to read in a question related to QT will be that it is representing a combination. What I mean by combination is that 2 electrical activities have been demonstrated to be present for causing the QT interval. One is the presence of the QRS complex, that is ventricular depolarization. And the second one is the T wave is also part of it. So that would be called as ventricular repolarization. Now, what you need to know is that for this QT interval, again, they are going to put up questions like what is the normal duration? And the normal duration of this should be remembered as an average of about 400 milliseconds. It's actually 360 to 440 milliseconds. So I can say like this, that in a normal person like you and me, this will fit into 9 to 11 small squares. And if it's going to be like more than this, then I'm going to say prolonged QT. If it's going to be short, then I'm going to say, less than that, I'm going to say it a short QT. And the heads up that I want to give right now is that QT interval will always be having an inverse relation with calcium. This is the second time I've given an inverse relation in the ECG. First time I said PR interval has a inverse relation with the heart rate, and now I'm telling you that QT also has an inverse relation with calcium. And therefore you will notice that in all questions of tetany, tetany would be usually given after thyroid surgery. Parathyroid resection has occurred after a total thyroidectomy. And you'll notice that all questions of tetany by default will always have the word written, a prolonged QT interval. On the other hand, if he gives you a scenario of hypercalcemic crisis, like lung cancer is a cause for hypercalcemia, breast cancer, multiple myeloma. So all those questions, lung cancers, whether it's squamous cell carcinoma, whether it's going to be breast cancer, they all produce PTHRP, that is parathormone related peptide. And when the calcium values will spike, you will be getting is a short QT given by default in all such questions. I mean, every time, in endocrine section, you will read about hypercalcemia. One option in the MCQ will always be QT, and you just need to follow the inverse relation there. So at this moment, what I've tried to explain to you is that the P wave of yours and mine will fit into 3 small squares horizontally. When it comes to the PR interval, it would be approximately 3 to 5 small squares. So try to learn it here only, guys. Just mentally visualize P wave because of the activity of the SC node is fitting into 3 small squares horizontally. PR interval would be 3 to 5 because we are going to talk about short and prolonged subsequently. Then the Q wave will fit into 1 small square horizontally. So I can say less than 40 milliseconds. QRS is going to be 80 to 100 milliseconds, that is 2 to 2.5. And then QT is 9 to 11 small squares respectively. You can take an average of approximately 10. That would be like a good value to remember, 400 milliseconds. Now you can see that why I was discouraging you from remembering in that point system, no? Because 0.04 and 0.4 decimal system can cause error of judgment in the question. And therefore, like this has been asked in the paper also, that what is QT interval. Options were 0.04 also and 0.4 also. You can see that if you remember it as 400 milliseconds, it would be easier for you to calculate, in my opinion. Now, when it comes to the T wave, guys, the T wave is basically due to ventricular repolarization. And in T wave, we don't take into consideration the duration. We take into consideration the vertical height. Yes, guys, for T wave, T for tiger, we don't take into consideration the duration. We take into consideration the height. And the vertical height of the T wave would be less than 5 millimeter when it comes to limb leads. Now, why would you be having to remember all that is because subsequently I'll be saying words like tall, dented T waves. Tall dented T waves is what we read in literature of hyperkalemia. So if I say the word tall dented, right, so you should know more than how much that would be, more than 5 millimeter with respect to the limb lead. And the chest lead criteria are a little different in the sense that the vertical height is less than 10 millimeter. So first and foremost, like we will talk about things like hyperacute T waves, tall dented T waves. So to understand all those terminologies, the baseline information should be remembered. And then comes that question, U wave. Like this was NEET PG. I think the question said like U wave is seen due to. So your answer would be that U wave is a normal finding and it is occurring due to. Yes, guys, it is a normal finding. I know that you are going to be saying, sir, no, we have read in multiple subjects that hypokalemia contributes to prominent U waves. The word is prominent U waves, no, not normal U waves. So your answer would be that this is a normal finding. It is because of the delayed repolarization. The statement is delayed repolarization of the papillary muscles. Most of the time, this is a little unlikely to be seen if the heart rate is usually more than like 70s, or like if heart rate is usually like less than around about 60s or a little slower. Like some people tend to exercise a lot, so they have a high vagal tone. So they could be having a resting heart rate of 55, 60. I mean, that is the value when most of the time the U wave can be seen. But at a faster heart rate, it usually tends to get a little obliterated. It may get buried into the T wave. U wave, even if it is present, it may be missed at a faster heart rate. Why? Because the faster heart rate will cause all the complexes to come closer. So the U wave will also come closer to the T, and it will usually get buried in the activity of the T wave itself. The vertical height is always less than 1 millimeter, and usually like lead number V2 and V4 are good to check out the presence of the U waves. So my first objective has been to talk about like normal parameters at the moment. And once we've done that, one more additional point that I would like to add. Like I can use a different marker for this one. The end of the S wave, where I put the current marker, that is the end of the S wave. This, guys, is the isoelectric point. This is what is also written as J point. J point is also called as the isoelectric point. And following this isoelectric point would be the starting of the ST segment. So this particular area that I've currently shown, that is the end of the S and the starting of the T wave. The end of the S wave and the starting of the T wave is the ST segment. You will notice that there are two terms being used. One is interval and second is the segment. For interval, it is the start point and the end point. But for ST, it is the end and the start point. If you missed it, I'm going to say this again. Just look at this representation, and I'll use a different color to introduce a bit of contrast there. My point is, guys, this particular area that I'm currently marking in yellow, you will notice that I'm saying end of the S. The word is end of S, and then I'm saying starting of the T wave. So the words that I used were end and start. But if you look at the QT part, it was starting with the Q and end of the T. No? So the English words are ulta, and therefore this particular representation that I have done before you at this moment, I've just make it a more contrasting. Yes, more color is more contrasting at the moment. ST segment has been shown at the moment with respect to the isoelectric segment following the J point, which is also called as the isoelectric point. And these normal waves of the JVP are like, for starters, we need to understand this information. Now, once we've done this, our next objective would be that how do we calculate heart rate? So every time you get a question in the paper with respect to ECG, the first 5 seconds of yours, the roadmap is to calculate the heart rate. And for calculating the heart rate, all you need to do is check out the R wave and the R wave, and then you need to count the number of squares that would be separating the R and the R. Like here, you can see about 5 large squares separating R and R. If I move down, you can see that the number of these squares are progressively reducing. So why am I doing this counting before you is not to teach you mathematics, but to simply tell you a formula that is 300 divided by RR interval. 300 is, that's the formula to be remembered. 300 in the numerator, and in the denominator would be RR. That is the number of large squares. In ECG, guys, everything that I'll be teaching you is always with respect to the small square. Everything that we discuss in ECG is always with respect to the small squares. The only time when I would be requesting you to remember large squares is whenever you have to calculate the heart rate of the patient. And now let's do a bit of mathematics here. The mathematics would be as follows. Like the first representation that I've shown before you, there are like 5 large squares. So 300 divided by 5 would be a heart rate of about 60 beats per minute. So the patient is technically not having a bradycardia because normal heart rate is 60 to 100. But if it would have been a little more than this, then I can say bradycardia would have started. Then most of us, while we are sitting comfortably on a chair, like you at the moment would be sitting and listening to me, then your heart rate would be approximately 75 beats per minute. So your RR would be separated by like 4 large squares. When it comes to, suppose you are exercising, or if you're trying to climb stairs fast, suppose 2-3 flights of stairs and you're trying to run fast, then your heart rate will increase to 100. But then people could be having arrhythmias where the heart rate could be going up to something like 150 beats per minute. That is a cause of concern, palpitations. And then look at the astronomical rate that I'm writing, 300 per minute. That's gonna make the person very, very uncomfortable. So what I wanted to teach you was that in tachycardia questions, you will always be noticing that the number of large squares will always be less than 3 large squares. You can see that 3 is for 100 now. 3 is for 100. So if I say that if a person is having tachycardia, then tachycardia would be technically defined as RR interval separated by less than 3 LS. LS means large squares. On the other hand, if I say more than 5 large squares, 300 divided by 5 was 60. If it's going to be more than 5, let's make it 6, or let's make it 6. If I make it 6, 300 by 6 would be 50. That is a bradycardia. So at the moment, like I said, in the first 5 seconds, whenever you scan through a ECG, what are you supposed to do is just check out the heart rate of the patient. Remember the number 35, that if it is less than 3 large square, it's going to be a tachycardia question. If it's more than 5 large square, it's going to be a bradycardia question. And that will change the entire game, because in tachyarrhythmias, then things are different that need to be evaluated. Or if in bradyarrhythmias, it is heart blocks that need to be studied. So right in the very first 5 seconds, every time you check out an ECG, if you're going to just follow what I said, you at least get a direction that should I be following an algorithm for tachy or should I be following an algorithm for brady. And what I mean by brady is heart blocks would be there. And if we talks about like tachyarrhythmias, then there's so many of them that would be discussed. Atrial fibrillation, atrial flutter, PSVT, then ventricular tachycardia, ventricular fibrillation. So all of them would be discussed subsequently, but I just wanted to bring to your attention how to calculate the heart rate initially. Now, having said that, we'll talk about abnormalities of the P wave. If the horizontal P wave duration is more than 120 milliseconds, like what I've done here is, as compared to a normal P wave, I have deliberately, when I've sketched it, I'll just zoom it and slightly for your convenience also, you will notice that I've deliberately increased the duration of the P wave. And apart from increasing the duration, I've introduced a bit of that notch in between also. That slight notch may or may not be visible. Like in this ECG, okay, I mean, maybe, the ECG was recorded, so it with a good quality stylus, good paper, so we were able to figure it out. But even if that notch is not present, what I want you to understand is that the duration has been shown to be more than 120 milliseconds. And in those circumstances, you will say patient is having P mitral. Now, medical condition in which you get a P mitral would be left atrial enlargement. I mean the current, because left atria of the patient is enlarged, so therefore the current is taking more time to go across the left atria of the patient, which results in like enlarged left atria. Current takes more time to go across the enlarged left atria, so therefore the duration tends to be more than 120 milliseconds. So what you need to remember is the word LAE, left atrial enlargement. The statement to be remembered is LAE, left atrial enlargement. And one of the best examples of left atrial enlargement can be rheumatic heart disease in India with mitral stenosis. Because of mitral stenosis obstruction present, the left atria will tend to enlarge, and therefore one of the ECG findings that you will notice in this patient would be P mitral. Most guys are able to solve the question by English only. I mean, if I say P mitral is seen in from mitral word only, mitral stenosis, and when you look at whenever you think of the word mitral stenosis, first thing that should strike you is that the left atria of the patient is enlarged. Now we contrast this with a second time, the P wave, like I've drawn a normal one. And now what I'm doing is I'm increasing the vertical height. This time I'm not increasing the duration. I'm trying to increase the vertical height of the P wave. You can see they're very pointed P waves present. They're hitting almost like going as tall as the R waves per se. I mean, normally P wave is much smaller than the vertical height of the R wave, but here you can see that the amplitude is more. So the technical word is called as P pulmonale. And where do you get it? You get it in a patient of right atrial enlargement. Every time you have a right atrial enlargement, the vertical height tends to spike up a bit. And one of the best examples for this I can say is COPD. You're aware that if a guy is a smoker, then COPD would contribute to pulmonary artery hypertension. Pulmonary artery hypertension means right side of the heart will have to do more work, and therefore right atrial enlargement would be occurring. So lots of time they use short forms also. So let's do a quick practice here. When he says the word P mitral, your answer is left atrial enlargement. When it comes to P pulmonale, your answer is right atrial enlargement. And the fundamental difference is in mitral, it's the duration part that is increased. In pulmonale, it's the vertical part that is increased. And then there was a question in NEET PG which said pseudo P pulmonale. The moment you read the word pseudo P pulmonale, it means vertical height is more than 2.5, but in the absence of pulmonary artery hypertension. So the question then arises, what is causing it? Well, what is causing it is the electrolyte imbalance, that is hypokalemia. It was a one-liner actually, guys, but a straightforward one. Pseudo P pulmonale implies no pulmonary artery hypertension, still the vertical height is more. It's because of hypokalemia. And when I have discussed separately also, I mean, I've talked about ECG findings of hypo and hyperkalemia separately also, I've touched upon the basics behind it. Now, as far as the absent P waves are concerned, see, P wave are generated by SA node. If the SA node is not the boss, if SA node is no more the boss, I mean, SA node is like the CEO of the company. So he marks his presence by presence of the P wave. Now, if he has resigned, whatever be the reason, like in a tachyarrhythmia that I'll be explaining to you, atrial fibrillation, the ectopic foci will take over the heart and the SA node will be removed from the CEO post. So there is no signature of the CEO present, and therefore there would be atrial fibrillation occurring in a patient. That is where P wave is absent. Another condition is where the SA node has become like defective in old people, especially in geriatric age group, 70s, 80s. You might be having patients in whom the SA node of the patient will begin to stop firing intermittently, and the condition is called as sick sinus syndrome. So at the moment, I've told you a tachyarrhythmia which has an absence P wave, and then I've told you a bradyarrhythmia that has an absent P wave, and lastly is the electrolyte imbalance. I mean, electrolyte imbalances will suddenly come out from the bolt from the blue. So gradually you will get more used to this kind of information, because subsequently I've recorded a separate video again to tackle care of hypo and hyperkalemia, because they keep on getting introduced in between. So hyperkalemia, again, one of the findings that we see is absent P wave. Rationale is that hyperkalemia mainly causes repolarization activity to increase. So the depolarization activity becomes lesser. I mean, potassium is a electrolyte for the vector of repolarization. So the vector for depolarization is lesser, and therefore you would be having absent P waves. This has been asked as a all except MCQs. I've given you 3 situations for absent P wave: a tachyarrhythmia, AFib, a bradyarrhythmia, sick sinus syndrome, and then hyperkalemia with respect to P wave abnormality. So 4 have been discussed: P mitral, P pulmonale, pseudo P pulmonale, and then absent P wave. And now I'll be explaining to you regarding short PR interval. Now for this short PR interval, let's look at this line diagram. You see the current in the heart will always go from SA node to AV node. Then I've shown in dotted because vagus nerve innervates the AV node. As I said, vagus is like brakes in the heart, so there would always be a AV nodal delay. The AV nodal delay ensures that, why do we call AV node as like the gatekeeper of the heart, or why do we call it like a goalkeeper of the heart, is because it is designed that way. God has made the system in such a fashion that we would like to let the impulses gradually go into the heart. About 0.1 second is the time, that is time lag that we see at this particular point of time when the current is navigating through this area. That is why it has been shown in dotted. Now it is hitting the bundle of his. So I'm showing septal activation. This horizontal arrow that is pointing from left to right is indicating septal activation. The septal activation is occurring with the bundle of his. And now what I've shown is the Purkinje network. This Purkinje network will be innervating the entire cardiac muscle. So let's say this is the entire cardiac muscle which is getting innervated. You all know the fact that Purkinje is like the fastest conducting fiber in the heart. You all read about the conduction velocity of the Purkinje. That's going to be like approximately 4 meters per second. So what I want to show at the moment before you is that the Purkinje will then be sending the current from the inside to the outside of the heart, that is from the endocardial to the epicardial area, and normal a depolarization of the heart is occurring. Now what I will do is I will introduce a short circuit in the heart of this patient, and this short circuit is what is mentioned for pre-excitation syndrome, that this particular pathway does not have a decremental property. Like an AV node, no, that lot of time is wasted. Now the current will prefer to go through this so-called express highway. So express highway is always faster. You see, AV node is like a broken Indian road. The conduction speed is slow there. So the current will always prefer to go through the pathway of least resistance, and therefore there would be an early excitation of ventricles. And this abnormal pathway which is present in the heart of this person and not in you and me is technically called as bundle of Kent. Guys, the condition that I'm teaching you is called as Wolff-Parkinson-White syndrome. It's called as pre-excitation syndrome, in which there would be a fast conducting pathway. And because of fast conducting pathway, even when this patient is sitting on a chair, there's a possibility that the heart rate of this patient can be more than 100 per minute. Therefore, usually the complaints of these people would be palpitations. You see, the main point is there is no decremental property here. Normally, AV node has a decremental property because of the vagus. There is no vagus nerve innervation here. So the ventricles will get excited earlier. And now the current will be traveling like this directly in the ventricles. And by dotted red, I'm showing current is not going to utilize the Purkinje network. This medical condition also has what is called as intermyocyte conduction. What I imply by the word intermyocyte conduction is that the normal conduction system of the heart is not being utilized. The Purkinje network is not being utilized. It is rather an intermyocyte conduction, which will be slower as compared to the Purkinje network. And Purkinje, anyway, as I said, is the fastest conduction pathway in the heart. Now, so far so good. Why are we studying this? What's the importance of studying this? The importance is that because there will be an early excitation of ventricles, because the current will travel very fast. So the ventricles will contract very fast. And when I say like this, the query of most people is, sir, what's the problem if ventricles are contracting early? Guys, the problem is if you have an early contraction of ventricles, then ventricles will not get time to get filled with blood. You see, ventricles need time to get filled with blood. If you get excited them early, there would be a contraction of partially filled ventricles. That's the problem, guys. Because of the fact that the ventricles are getting excited early, they did not get time to get filled with blood. So there's an early contraction. There's a premature contraction of a partially filled ventricle. And because the ventricle is partially filled, that implies that the output from the heart is less. Because if input in the heart is less, the output from the heart will also be less. And therefore, these patients can be having syncopal episodes also. Yes, guys, the condition that we're studying is Wolff-Parkinson-White syndrome. It can occur as a sporadic condition, or it can have a familial basis where the pattern of inheritance can be autosomal dominant. But on a common, like if he says usually what is the most common cause, your answer is sporadic mutation or sporadic reasons behind it. From the electrophysiology part, there are 3 points I said. First and foremost, the abnormal circuit is called as bundle of Kent. The second point is this is very fast conducting and has no decremental property. Current always goes through the pathway of least resistance. So ventricles are going to get excited earlier. And because of the early excitation of ventricles, the problem is because the heart did not get time to get filled with blood. If input is less, output is less, and therefore syncopal episodes can occur in patients of WPW syndrome. Now, on the basis of this, I'll discuss a question and then ECG findings. One of the specific ECG finding that I would like to say for this person will be always a short PR interval. Why short? Because I said there is always going to be a fast conduction. Even while sitting on a chair, the heart rate of this patient can be almost like 100 per minute, as or more than 100 per minute. So the person can be complaining of like, he'll either, the complaint will be that my heart rate is higher than normal people, or he will say that I get the pounding sensation in my chest so many times. And for this, the patient's parents would also, usually it's like young people who would be coming to you with their parents. So let's look at a case like a 17-year-old boy. He has come with complaints of palpitations or recurrent fainting episodes in the school assembly. And his mother says that currently he's not having any symptoms. He's totally okay. And the mother is a little disturbed because she says, my son has applied for ND exam, that National Defense Academy. And she says, like other boys in the class also, he wants to be, going into, a job which requires a lot of physical fitness. And she's a little not very comfortable about it, because she says, my boy is very weak. He keeps on fainting, sir. And like, I just want to come. I just have come to you for an opinion. At the moment, she's saying, my son is not having any complaints. But anyway, when I checked out the ECG, I checked the heart rate of this patient. So you can see that something like, if I counted, you should always do it at least counting twice. So if you look at the heart rate of this patient, that would be like something like 4 large squares separating the R and the R. So at the moment, like the heart rate of this patient is doing pretty decent. Like there are no symptoms at this particular point of time. So I can say that the heart rate currently is about 75 beats per minute. But on close observation, in fact, I'll just write down the value here also, like on ECG analysis, the heart rate of this particular chap is 300 divided by 4, that is 75 beats per minute. Now I'll focus on the PR interval, and that is what you will notice. The normal PR interval is like 120 to 200 milliseconds, but in this case, you will notice that the PR interval of the patient is very short, something like maybe 1 to 2 small squares only. So one of the very foremost things that we are noticing in this patient is a short PR interval. Normally, short PR interval is seen whenever there's a tachycardia, but this guy is not having a tachycardia. Still, the PR interval is relatively short. Let me just draw the ECG so that I can explain the finding of this patient relatively better. Like if you check out the ECG of a normal person, it would be something like this, the P, then QRS, and you can notice that very characteristic PR interval that I had mentioned in a range of about 120 to approximately 200 milliseconds. In this patient's ECG, the moment the P wave is finishing, you can cast a glance at the actual ECG also, and what I'm drawing, you will notice that there is no Q wave. The moment the P is finishing, you are noticing that in this patient, there is a R wave that is coming straight away. And then subsequently, like you can see a T wave coming in the ECG of this patient. Now, what I want to draw here is, and I'll zoom it a little further, is as compared to normal PR interval, it is shorter. And what I've also tried to say is that in normal person's ECG of like you and me, the R wave will go straight up. But here I've tried to introduce a slope in the upswing of the R wave. And this change of slope in the upswing of the R wave is one of the key reasons why we're discussing this topic, guys. If you check out the ECG of this patient at this particular junction, I'll just put some pointers. This areas that I'm marking where the R wave is starting, just where the R wave is starting, the upswing of it, it doesn't look like to be going up straight. I'll zoom it in. Like it doesn't look to be going up straight. There's a slight change in the slope. There's a slight change in the curvature. And that is like one of the keywords for identifying this question. That would be presence of delta wave. So every time they will give you a question on the topic of WPW syndrome, you'll notice that there would be the following findings present. The heart rate of the patient will be decent, but in spite of the fact that the heart rate is normal, there's a short PR interval because I said there's a fast conduction system in the heart which is causing the current to bypass the AV node and directly go into the ventricles. The Q wave in the ECG of this patient would be absent. Let's look at this diagram once again. Why the Q wave is absent? Just follow my marker. You see, Q wave comes because of septal activation. When the current hits the bundle of His, if the current is going the normal pathway in you and me, it goes from SA node, AV node, then bundle of phase, that is septal activation which causes Q wave. But here current is not going via the normal way, it is bypassing the entire circuit. It is going like this directly in the ventricles of the patient. So as a result of this, what you will notice for these patients would be that there would be no Q waves present. That again is a hint towards presence of WPW. Then is obviously the main aspect that I said that the slope in the upswing in the R wave will not be normal, that is delta. And then is PJ interval. For PJ, again, I'll have to give you a short description, and then I'll focus on like what is going to happen to the PJ interval of this patient. So to come back to the slide, I want you to look at the following information. You can just stop looking at your notes at the moment or checking out your notes. Just focus on the mathematics that I say before you. I'm showing perfectly normal thing at the moment. You see, starting of the P wave and starting of the Q wave is what is called as the PR interval. This is what we have already spoken about. Then I've also told you that the end of this S wave, this is what is called as the J point. Like I marked the J point once again, it is called as the isoelectric point. And what I want to say before you is that the distance between this black point and the blue point is what is called as the QRS complex. And if I join the two together, I get a new parameter that is called as PJ interval. Guys, at the moment, I'm trying to introduce a new concept that I've not introduced previously, so I would need max of your attention. The distance between the two black points is called as PR interval, and the distance between the second black point and the blue point is what is called as PJ interval. So one, I've told you PJ interval is the sum of PR plus QRS. Now let us look at what happens with respect to patients who are having WPW. In WPW, the PR interval is short thanks to the fast conduction occurring by the bundle of Kent. As I've told you, like, once there's a fast conduction, the PR will become relatively smaller, though in spite of the fact that the heart rate of this patient may not be significantly affected. The second thing that you'll notice is the Q wave in the ECG of this patient would be absent, and now we're left with RS complex. For the RS complex, the rationale I want to give you is that these patients' heart is not having normal conduction. Like when I was describing the ventricles part to you, the current was not going by the Purkinje fiber. The current was directly going from the muscle to muscle, or from the myocyte to myocyte. There was an intermyocyte conduction, and this intermyocyte conduction is always slower than the conduction in the Purkinje. Now I want you to read this statement. Intermyocyte conduction is slower than Purkinje. Just focus on the word slow and tell me what will happen to the RS complex. The word is slower, and I want you to say it loud to yourself. But focus on the word slow and tell me what's going to happen to RS. Will it be narrow or will it be relatively more broad? Yes, the logic is slow means it would be relatively more broad. So the final summary is, guys, that in WPW, the PR is going to be short. The Q of this patient might turn out to be absent. The RS of this patient is broad. Now, what we see in clinical studies is that the reduction of the PR interval is equal to the prolongation of the RS complex, because the reduction of the PR and the prolongation of RS complex, no MBBS now, only mathematics, guys. Mathematically speaking, if PR will become less by, let me say, 5 points, 5 milliseconds, and RS will become broader by 5 milliseconds, then both will counterbalance each other. And therefore, what will be the impact on the PJ interval? The PJ interval in a case of WPW will remain normal. Why I'm saying it is normal? In spite of the fact it is normal, guys, still it's a diagnostic criteria. Now, why? Because one parameter is becoming lesser and the second parameter is becoming more, and the amount of reduction is equal to the amount of increment. Like the PR interval reduced by 5 milliseconds and the RS complex increased by 5 milliseconds. So both are counterbalancing each other mathematically, and the PJ interval is normal. This itself is a point, and you will realize the importance of this in a couple of minutes from now when I teach you one more condition that is called as Lown-Genong-Levine syndrome. At the moment, the learning point is, traditionally we always read about that PR interval is affected with heart rate. I stand by that. But in these patients, in spite of a normal heart rate, still you could be having a short PR, primarily because of that aberrant conduction or accessory pathway present in the heart. And even if you don't remember all of this, I can still say you can solve the question by just picking up the delta wave. Delta wave would mean that the upswing of the R wave will not be straight up. It will have a slight change in the slope in the upward deflection. And that is like the main reason why we've gone into this discussion. So the clinical diagnosis of this particular case is, the clinical diagnosis is delta wave. And the mother says, can my son be an army officer? So I tell her, ma'am, that it's not a good idea actually, because this guy, he can have these syncopal episodes during his training and he can even die. So you will have to somehow tell him, not discourage him, because that, sometimes young people are very inclined to have a particular type of a career. We'll tell this guy that jobs which requires stringent, physical fitness. I mean, in army, when they'll make him do front roll, back roll, and make him climb rope, etc., his heart is not designed for it, because the fast beating of the heart is the troublesome fact. The fast beating will cause a drop in the cardiac output. He can have a syncopal episode and injure himself. So he can get into any blue collar job, or white collar job, as compared to job where like a lot of physical fitness would be required. And now the question would arise, like, what should we be doing for the management of this condition? And he has asked, like, drug to prevent recurrence of symptoms, what is the treatment of choice? So the treatment of choice would be that we will be telling this chap that you have to come to the hospital and we are gonna fire a laser beam, and this laser beam will destroy the abnormal circuit in your heart. And we also have to explain him that you are born with, like, you are a lucky child fellow man, you are having two conduction systems in your heart. One is the normal one, second is the abnormal one. So we're gonna fire a laser beam and destroy the abnormal one. You have to make it lighter on him, right? Young people tend to be very sensitive about illnesses, right? So radio frequency ablation, RFA, is the treatment of choice. Don't answer a pacemaker here, guys. Don't answer implantable cardioverter defibrillator. It is a radio frequency ablation that needs to be done. Now, when I told the mother, she said, okay, we'll get it done. But then I would like to take a second or a third opinion. But till that time, can you write me a medicine so that my child does not have these, fast palpitation episodes multiple times? So I said, okay. And the medicine we can give in these patients is flecainide. You see, people with WPW may not be having symptoms when they come to you, but their ECG will still give you evidence, and flecainide can be given to prevent these episodes from occurring. But if he says that he's having at the moment palpitations, like same patient, like he did not take the medicine, and then he was like, playing in the school, playing with his friends, and he was trying to run fast. That's when either he had a syncopal episode or he did not feel well, because of the fast beating of the heart can make any person feel very uncomfortable. So we'll admit this patient and start him on procainamide. So drug of choice for accessory pathway mediated tachycardia. He'll not write the word WPW, like he's just playing with English here. It is accessory pathway mediated tachycardia, where procainamide, meaning of that is WPW only. In emergency, the learning point is emergency situation, it is going to be procainamide. Otherwise, for prevention part, that is we are going to be using flecainide, and the definitive treatment is radio frequency ablation. As you can see, even in this diagram, the current is bypassing and is directly going into the ventricles. It's not causing a septal activation. Normal person like you and me, the current should be going like this. It would start from the SN node, hit the AV, then in AV it will be slow, then there is a septal activation, then it goes into the left vesicle, some current to left vesicle, and then spreads by the Purkinje network. But in this case, there's a direct short circuit which connects the atria to the ventricle, and you can see this accessory pathway is the troublemaker in this patient. So we need to fix that problem in this person, and one of the main pickup points in the question would be presence of delta wave. At this junction, I also want to just remind you that in the neurology section and even in your physiology classes, you would have read delta wave in EEG also. So if he says delta waves in, like, it changes the entire domain, right? I was talking about ECG finding, now I'm saying EEG. Then this is perfectly normal, guys. Delta wave can be seen in EEG, electroencephalography, with respect to a particular phase of sleep that is called as NREM stage 3. So a miscellaneous question has been added to your vocabulary. Delta wave in ECG, WPW, and a delta wave in EEG, electroencephalography, is NREM stage 3. Now I'll compare this with Lown-Ganong-Levine syndrome. Now I'll again draw a line diagram here, so please be patient while I just draw this here. The current goes from SN node to AV node. That's the vagus showing its effect. So AV node are delaying the gatekeeper. Then the current enters into the bundle of his, which is having two vesicles, the left one and the right side. This is the septal activation. Then current usually first goes to left, that's normal. First goes to left vesicle, then to right, then enters into this Purkinje network, which is very extensive. In fact, in FMG exam, they said, what is Purkinje fiber? Purkinje fiber is a modified muscle fiber. I'll just write it down. What is Purkinje? It's a modified muscle fiber. Look at the height of evolution, guys. Modified muscle fiber, it's behaving like a nerve. What was I saying? Purkinje fiber is conducts at 4 meters per second. Why it should ring a bell is because heart is supposed to be muscle, but there are some muscle fibers which are behaving like nerves. It is responsible for conduction. So one, we read about Purkinje cells in the cerebellum, but I'm teaching you regarding Purkinje fibers. The data is Purkinje fibers per se, you need to remember, tend to have the fastest conduction, and 4 meters per second to be precise. Why I emphasizing that is because heart is always supposed to be a muscle, but in this case, this is behaving like a nerve fiber. It's a modified muscle fiber primarily, and this would be innervating the entire myocardium and would be allowing the current to go from inside to outside. But in the case that I'm describing now before you, I'll show you a short circuit, and this short circuit will be like this. It will bypass the AV node. You can see that the short circuit is bypassing the AV node, and there's a difference in the diagram that are drawn at the moment before you in contrast to that of WPW, because in WPW I was making the abnormal circuit directly go into the ventricles, but here the current is not directly going into the ventricles, it is just bypassing the AV node. but bypassing the AV node will still save some time because the vagus nerve impact has been vegetated. So even these patients would be having a fast conduction, and therefore he will ask you what is the name of this abnormal conduction pathway that is seen in Lown-Ganong-Levine syndrome. The name of this that you read in one basic sciences would be James bundle. Apart from James bundle, another conduction system that can be present in these patients are called as Mahem fibers. So there are two of them, two different ones that I mentioned. One is called as James bundle, another one is called as Mahem fibers. So these are like two levels at where accessory pathway, or two names of two different accessory pathways that can be present in this patient. The clinical findings in this patient will be same in a sense that it's a young guy who's having palpitations and can be having syncopal episodes, and because it's mainly the palpitations which are going to be troublesome because the current will bypass the AV node. In this person's ECG, you can see that Q wave will be occurring because ultimately still septal activation will occur. Now, I agree to the fact that I've shown it a little like, and joining a little later in the part of the bundle of phase, but still the current is going in the bundle of phase. Now, if the current will go in the bundle of phase, it will still contribute to a septal activation. So you will get a Q wave in this patient. And the most important thing in this patient is that because of the fast conduction through the black fiber, that is James bundle, there would be a short PR. Q will be present due to septal activation because current is ultimately going in the bundle of phase. And then subsequently there would be a QRS complex because the current will now be able to utilize this entire circuit. Like in this person's heart, Purkinje network will be utilized. Unlike in WPW, I'll just show you the diagram of WPW. In WPW syndrome, guys, you notice that the Purkinje fibers were not being utilized. It was all the way intramyocyte conduction, which was for the left ventricle and the right ventricle respectively. But for these chaps, it's gonna be like the current diagram. You can see the current ultimately goes finally utilizing the Purkinje network. So the QRS of these patients would be normal. And now we look at PJ. Reminding you once again, PJ is a sum of PR plus QRS. Mathematically speaking, now no MBBS, only mathematics. What will happen to PJ if the PR is short? Your answer would be that if PR is short, QRS is normal, PJ will also become short. And this was a question in FMG exam. Yes, guys, FMG exam has also become more difficult in the recent couple of years. They asked what is the difference between WPW and Lown-Ganong-Levine syndrome. Both conditions are having a short PR interval, but the difference, a very important one to be remembered for the paper, is obviously the Q wave thing is obviously the difference. But apart from that, the main difference is that PJ interval will be normal. I'll show you the slide where I calculated that for you, that the PJ will be normal for WPW, but PJ will be short for patients of Lown-Ganong-Levine syndrome. As far as the treatment of this condition is concerned, the treatment is same as that for WPW. Whatever I said for WPW, like we'll do a radio frequency ablation, we'll give flecainide for prevention of episodes, we'll be using procainamide. So all the things that I've said in the treatment part, because it's still an accessory pathway now, so fire a laser beam and get rid of it. The only reason why it will be asked to you is that they want to know, there are only 2 points to be remembered on this slide. First, they will ask you regarding what is the name of that accessory circuit which is present, or they will ask you regarding fundamental difference between the two. WPW PJ is going to be normal, whereas in this case the PJ will be short. Radio frequency ablation is the common treatment given in both of them. Based on this, now I'm in a better position to mention that short PR interval can be seen in any condition like tachycardia. Reason for tachycardia can be like Graves' disease, anxiety, neurosis, panic attacks. All of them can result in development of tachycardia in a person. So one, generally speaking, like tachycardia or sinus tachycardia, they are like short PR interval. But over and above this, I've taught you conditions in which you could be having is a normal heart rate, but still the PR is relatively lesser. That is Wolff-Parkinson-White syndrome and Lown-Ganong-Levine syndrome. That does not mean that they'll not have, they can have a normal heart rate or they can be having a faster heart rate. Any of the two can be a possibility. But then PR interval is universally short in these patients. And now I want you to imagine a patient of rheumatic fever who's having Ashkoff nodules in the heart. People who are having Ashkoff nodules in the heart, what will happen is that there would be Ashkoff nodules. Like let's me symbolically just show these black spots as Ashkoff nodules, which are occurring in the pathway connecting the SA node to the AV node. And because of this, there would be a decrease in the conduction velocity. You can see that the Ashkoff nodules are slowing down the conduction. So therefore, prolonged PR interval is also read in rheumatic fever. When you listen to the rheumatic fever component, I have said that one of the minor diagnostic criteria for diagnosis of rheumatic fever is prolonged PR interval. The reason for that being that these black dots that I've shown are going to be Ashkoff nodules, and they would be slowing down the conduction with respect to the area between the SA node and the AV node. The second cause for this is first degree heart block. First degree heart block can be physiological also. The definition of first degree heart block would be that the PR interval of this patient would constantly be more than the upper limit of 200 milliseconds, though this can be seen physiologically also in people with high vagal tone, especially like people who do a lot of exercise, marathon running for example, or rock climbing for that matter of fact. Vagal tone, high vagal tone can be one of the reasons for development of first degree heart block. Now, though I've discussed the bradycardia's component separately, but I'll just say the statement at this moment that a question in NEET PG said that a young guy has been hired by a IT company and you are the doctor on the medical board, and the guy's PR interval should be more than how much to say it is first degree heart block. Like he said, you are like on a medical board of IT company, you are doing a screening, and it's for a sedentary job only. Like IT company will not be making somebody do rope climbing and front roll and back roll, so it's a desk job only. But he said, like, as a doctor, like what should be the threshold that you should be scanning in the ECG of this particular guy's opting for a sedentary job or desk job primarily, then it is PR interval more than 200 milliseconds for first degree heart block. The next condition that you need to remember is called as Mobitz 1 heart block. Mobitz 1 heart block is characterized by serial prolongation of the PR interval. When you scan the ECG of these patients, you will notice that this guy is sitting comfortably on a chair and his PR interval is progressively rising. Like at the moment, you can see that I've shown a PR interval increasing and increasing and increasing, and subsequently this guy might even be having missed beats. Like you might get a P wave and then there would be no RS complex occurring in this patient. Now at this moment, I just want to draw your attention to the fact that what I have shown before you can be a manifestation of beta blocker toxicity. If you prescribe too much of beta blockers to somebody, then you will notice the PR interval will increase and increase and increase, and then it can increase so much that there can even be missed beats where also the patient will disappear intermittently. If you look at this representation that I made before you, suppose the PR interval first time, let me just give it a mathematical touch here. Suppose the PR interval that I have written for this patient the first time was normal, that was 160 milliseconds. But because of beta blocker, subsequently it became 200 milliseconds and then it increased to, let me say, 240. So every time you get is a serial prolongation of the PR. The word is serial prolongation of the PR interval. The condition is called as Mobitz 1 heart block. The alternative name for Mobitz 1 heart block that you need to remember is called as Wenckebach phenomenon. The alternative name for this particular condition that you need to remember is called as Wenckebach phenomenon, and this can be a manifestation seen even with excess of prescription of beta blockers. If you reduce the dose of beta blockers gradually, like this condition is bound to improve. But I've shown like 3 conditions where prolonged PR interval can be present as of now. That can be rheumatic fever, first degree heart block, and then Mobitz heart block. And usually this question on the right side will be like a all except 1. So PR interval is normal in Mobitz 2 heart block. Now why it is normal in Mobitz 2 is primarily because in Mobitz 2 the problem lies below the level of the AV node. If the problem is below the level of, I told you, PR interval is valid only till the AV nodal conduction. In Mobitz 2 heart block, the problem is below the level of the AV node. So we will not have any change, and PR interval is normal in Mobitz 2. So there are like total 7 points on this slide. Let's do a quick recap. Short PR interval for tachycardia conditions, WPW and LGL. So if they make me compare short versus prolonged and they give me these situations in combination, 3 on the left or 3 on the right and 1 from the left, I can figure them out. But they also can put up a question that all of the following will be having prolonged PR intervals. So reading the word heart block, the impression that comes is, if we focus on only English, the word heart block, the impression is that PR will be prolonged. But I told you one specific variety of heart block where the PR interval should be remembered by you as normal, and that is called as Mobitz 2 heart block. It's a defect which is below the level of the AV node, which is why in these patients the PR interval is not affected. And this entire slide caters to abnormalities related to PR. So my focus would be teach you abnormalities of P wave, then PR interval, then QRS complex, then the ST segment, the QT interval. That would be my focus so that we can analyze the ECG relatively better. Now there are multiple pacemakers in our heart. SA node, AV node, bundle of Purkinje, you all know about it. The SA node fires at a rate of 60 to 100 times per minute. Suppose the SA node malfunctions. Then the AV node will take over. And if AV node will take over, what will be the max ventricular rate of the patient? 45 to 60 beats per minute. Suppose the top two pacemakers will malfunction. SA node is also malfunctioning, AV node is also malfunctioning. Then the bundle of phase will take over, and bundle of phase max firing rate is less than 40 per minute. God has given us backup generators, right? If SA node malfunctions, AV node will take over the heart, and therefore firing rate would be 45 to 60. The top two will malfunction, bundle of phase takes over less than 40. If the top three pacemakers malfunction, then Purkinje will take over. What is the intrinsic firing rate of the Purkinje? Remember earlier I was saying Purkinje conducts like a nerve at 4 meter per second. I'm saying it is now capable of firing by itself also at 15 to 20 beats per minute. So one, God has given us 4 pacemakers. And the learning point at the moment is, suppose if the SA node is destroyed, then what will be the maximum ventricular rate of the patient? 60 per minute. If the top two are destroyed or AV node is destroyed, what will be the ventricular rate? Less than 40 per minute. If even bundle of phase is gone, then Purkinje, it's a little difficult to survive at 20, so we will require atropine for the patient. But I just wanted to sensitize you that whenever a pacemaker will malfunction, the one below it will decide the ventricular rate of the patient, and you can use this to remember the following information. If a person is having SA node malfunction, suppose in old age, the SA node has stopped intermittently firing, then the condition would be called as sick sinus syndrome. And the highlight of the sick sinus syndrome will be that the SA node intermittently will fail to fire. If the SA node of the patient intermittently will fail to fire, what you will get in these patients subsequently will be the following impact, that the P wave in the ECG would be absent. I said that earlier also, absent P wave would be present. Plus, what will be the maximum heart rate in this person? Then the maximum heart rate in this patient would be about less than 60 beats per minute, because I explained to you that if SA node will malfunction, then AV node will decide the ventricular rate. Even while you're sitting comfortably listening to me, your ventricular rate is still more than 60. Here, the max possible will be 60. So this is how the ECG will look like. When I scan the ECG, no P wave. Then I'll get a QRS complex. I can get a T. And then subsequently, again, I will notice that in this person's ECG, there might not be any absence of P, may not be presence of any P wave. I've shown a QRS complex that is happening, followed by a T. Then you can see intermittently, the SA node has started firing once again. So when you scan through the ECG of this patient, you might be noticing somewhere the ECG can be normal also. What I mean by normal is that the P wave can be visualized. But intermittently, you can notice that there is complete disappearance of the P wave. This manifestation that I've currently shown before you, where intermittent disappearance of the P wave is present, and the heart rate in this patient will be a maximum of like 60 beats per minute or lesser, then we will say it is sick sinus syndrome. So you need two things for it. If it's a tachyarrhythmia with absent P wave, it's atrial fibrillation. But for a bradyarrhythmia, where the heart rate is less than 60 and P wave is absent, it is sick sinus syndrome, usually seen in geriatric age group. Now let's compare this with what will happen if the AV node will malfunction. If AV node will malfunction, then the disease that occurs is called as complete heart block. So earlier I was saying words like Mobitz 1 and Mobitz 2. Now I'm saying the word complete heart block. Complete heart block, every time you read, it should tell you in your mind that it is the AV node that is malfunctioning. And therefore what will happen in the patient would be that it's literally like a divorce between the upper and the lower chambers of the heart. Why I'm saying it is a divorce is because AV node is standing in the between, and it is that link that connects the SA node to the bundle of phase. Now there is a divorce between the two systems. SA node will do its own thing. It will fire at a rate of 100 times per minute, and bundle of phase will fire at a rate of something like 40 beats per minute. You see, both of them can fire at their own rates. Now, if AV node will malfunction, then who will control the ventricles? The area controlling the ventricles, as I explained, was the pacemaker below it. So the ventricular rate of the patient will be 40 per minute, and the atrial rate of the patient would be 100 per minute. One of the things that you will notice in this question would always be that the SA node is responsible for generation of P waves. So how many P waves will you get in the ECG of this patient in 1 minute? That is maximum of 100, because that is the firing rate of the SA node. But how many R waves will you be getting in the ECG of this patient? Maximum in 1 minute, that would be only 40 per minute. This was a theory based question, guys. This was an FMG exam question. He said a patient has come to the hospital. It's an old man with syncopal attacks. So when one of my students read that question, he said, "Sir, you said old man, so I thought it is sick sinus syndrome." But when he described the question further, he said he did not say absent P wave. Absent P wave is a feature of sick sinus syndrome. The question was that P waves are present, but the number of P waves is 100 per minute, and R wave is 40 per minute. In all conditions in the heart, no number of P waves and number of R waves will always match. But here, like P wave and R wave number is not matching. I said it's like a divorce occurring between the upper chamber and the lower chamber of the heart. So both are saying we are gonna go our way. So both of them are doing their own thing, and therefore the technical term for this description is complete heart block, or there's an alternative name for this. The alternative name for this is AV dissociation. The moment you read the word dissociation, you can understand the divorce thing that I was saying. Or for that matter of fact, there's a third terminology which is to be remembered. Half the problem in medicine is that for the same disease, they tend to incorporate different names. So now you know that if AV node is diseased, you call it complete heart block, you call it AV dissociation, you call it Stokes-Adams syndrome, whatever be the terminology, the question will always describe an old man with multiple syncopal episodes, and then will say the number of P waves in the ECG will not be matching with the R wave, and your answer would be given as the topic of interest, complete heart block. As far as the ECG of this condition is concerned, I can hand draw the same before you. Like I'll draw it in color red to give contrast, like it is P followed by a P. Normally after P, you get a QRS complex, no? And then when you scan through the ECG, you are getting a R wave in this ECG. You may not, suppose let's draw a T, okay? Then a P followed by a P. And then like why I'm drawing more number of P waves? Why I'm drawing more number of P waves is because it is 100 per minute, no? Faster rate as compared to ventricles. So when you scan through the ECG of this patient, you can pick up the T from the P that is different. Let me draw one more RS complex. If you look at the ECG, guys, you can yourself see the number of P's that are drawn here. They are going independent. Atria are going independent of the ventricles. There are 3 R waves present in this ECG. I have not written the word R, it's obvious. There are 3 R waves present, and there are 6 P waves present, and there are 3 R waves present. So I can say like the atria are doing a much more faster job as compared to the ventricles. This condition is what is called as complete heart block, for which again a pacemaker would be required. The main concept to be remembered is complete heart block is like lack of coordination between the upper and the lower chambers of the heart. So as a result of this, the number of P and R waves will not match, and the PP and RR interval will also not match. Let us now look at the third topic that I described before you, which is malfunction of the bundle of phase. I'll use a different color to introduce contrast. If the defect is in bundle of phase, guys, this is not bundle branch block. The commonest mistake that most doctors think is that if bundle of phase is malfunctioning, it is bundle branch block. No, guys. Left bundle branch block is when left fascicle will malfunction. Right bundle branch block is when right fascicle will malfunction. I'm talking about the main central fascicle. If the main central fascicle is missing or is not working, we tend to call it Mobitz 2 heart block. Now, what will be the ECG in Mobitz 2 heart block is what I draw before you. This condition will always have a normal PR interval. You will notice that multiple complexes will be given in the paper like this. And every time you count the PR interval of this patient, it's gonna be perfectly normal. So lots of time, most people lose it in a sense that they tend to get restless because when 2-3 complexes, everything is normal. Like I've shown a PR interval at the moment. Let me put numbers here also. Like let me say it is 160 millisecond. It is 160 millisecond, it is 160 millisecond, it could be another 160 millisecond, after which you will notice that after T there is a P, and then I'm waiting, and I'm waiting, and I'm waiting, and this is like a sinus pause, man. I mean, the person's heart is just not doing anything. It's like literally the heart has forgotten to do what it's supposed to do, that is beat for entire life. And at this point of time, because nothing is happening, the ECG will put up a vertical line or a dotted vertical line like this to signify that this is the time when the person himself will say, sir, my head was spinning. He's sitting on a chair. He says, I was feeling as if I will fall down. And sir, when I check my pulse, I intermittently find that my pulse is disappearing. So most of the time, whenever they will give you Mobitz 2 heart block, they will always say this classical terminology that I'm saying, because the heart literally forgot to do what it is supposed to do. That is gonna be this vertical line signifies there is no QRS complex occurring. This is called as missed beat. The moment you read a missed beat and you notice that the PR interval prior to that is normal, you have to think in terms of Mobitz 2 heart block, and let's see what will happen. The heart will again start doing what it's supposed to do, that is start firing once again. There is a resetting of the cardiac rhythm, and you will be getting again everything normal in this patient. Now, drawn not more complexes. I just wanted to say to you that if you check out the PR interval even after the missed beat, no, it will be normal. If you check out the PR interval before the missed beat, actually the rule is that you should check out the PR. And every time they give you a question of missed beat, what you are supposed to do is check out the PR interval after the missed beat and before the missed beat. The mathematical value will always be equal, and this is the main diagnostic criteria for Mobitz 2 heart block. See, there are two ways of solving this question. One way is you count the PR interval the first time, the second time, the third time, and then you find out that, okay, fine, there is a drop occurring. That's one way, right? And the drop or missed beat that is occurring is PR interval is normal. Or the second way is just check it out two times only. Wherever they will mention missed beat, just check it out after and before. If it is equal, it is movements to heart block. When I describe it, the query of most people is, sir, what is the problem? If heart is resetting the rhythm, guys, the problem is this particular area. Just check it out. The RR interval of this patient, this marking that I'm doing, you can suddenly see there's a huge gap between the R and R. That means there would be a bradycardia occurring at this point of time. And just for the sake of mathematics here, what I will do is I will put some numbers. You don't need to do it in your notes. I'm saying just randomly because I don't have a graph paper here. So what I want to say is that I put some numbers there. Like, let me say I have put about 8 large squares separating the R and the R. So if I'll do verbal calculation, 300 divided by R. If I do 300 divided by 8, right, RR interval, that would make the heart rate is going down to 40 or even lesser than that. So what happens in these patients who movements to heart block is a sudden decrease in the heart rate that can explain syncopal episodes. Movements to heart block can contribute to sudden death in an individual. I'll just do the markings here once again, guys, so that you can understand this better. Like this, he will himself assist you by putting a vertical arrow. That vertical arrow signifies that there is a missed beat present here, and I'm just gonna put some numbers there, like 1, 2, 3, 4. I can increase them, I can exaggerate them just to make it more dramatic. Like, let me say 9, let me increase it to 10, right? 300 divided by 10, the heart rate goes down to as much as 30. That's even more lesser. So there is a high probability that these people can die. And this is primarily because of the slow heart rate that ensures, primarily because of the ventricles are missing to fire. So movements to heart block is a life-threatening condition, guys, where atropine would be required. Atropine dose has changed. Now it is not 0.6 milligram, it is 1 milligram. The max that you can give is 3. And I have discussed the bradycardia component even separately. Like you will notice symptomatic bradycardia and one of the subsequent videos also. So this will give you heads up to understand even that video much more better. At the moment, I have taught you right from top to bottom. The thought process of yours should be at this junction. If S node malfunctions, 6 sinus, heart rate would go down to less than 60, but at least the guy is not gonna become unconscious right now. But in movements 2, he will become unconscious right now because the heart rate is dropping to almost 30. When you look at complete heart block, then there's a divorce between the upper and the lower chambers of the heart. So number of P waves and number of R waves will not match. In the inferior diagram, when you look at the ECG, initially everything will look normal to you. So most people lose patience at this point of time. They think that, oh, I could not understand the ECG. And then you notice the moment you lost patience, after that was the hint that there was a substantial drop in the heart rate. There was a substantial increased RR interval of this patient, large number of squares present between R and R, and that would explain why these patients would be having is a development of syncope. So I can use the word neurocardiogenic syncope, because syncope is a neurological event and it's a heart that is responsible for it. So at the moment, I've tried to explain to you conditions where we get a prolonged PR interval, and you can see that PR interval is normal in movements 2 heart block. Even in this ECG, it is normal, and it's not that only after 3 there would be a drop. They could be 10 and then there could be a drop. They could be 15 and then there's a drop. I mean, I have limited space to sketch, so that's why I've shown it at the moment like this, that there's a drop after 3 only. But this is movements to heart block, guys. This can cause a substantial increased chances of mortality, and that is why atropine needs to be given and temporary pacemakers need to be utilized. Now we will talk about Q wave, capital Q wave. I told you that normally we get a Q wave due to septal activation. There are 3 conditions where you will read about the word capital Q. The first time you will read about capital Q would be myocardial infarction, that is indicative of cell death. The second time you will read about this would be in the video of hypertrophic cardiomyopathy, but I've given you heads up here. The hypertrophic cardiomyopathy would be a young guy playing football and then he dies suddenly. And the third condition where you will read it will be a little more expansive. He will say words like S1, Q3, T3 pattern. You will read about this S1, Q3, T3 pattern in the respiratory medicine section. That would be a topic by the name of pulmonary thromboembolism. Like this particular person was having deep vein thrombosis, and the clot of the deep vein thrombosis has embolized from the great veins or from like the soleal veins and then from the pelvic veins and has gone into the heart and is blocking the pulmonary artery, contributing to this characteristic pattern called as S1, Q3, T3. What that means is deep S waves in lead 1. What that means is presence of deep Q waves in lead number 3. And that T3 is for inverted T waves. That T wave, that is inverted T waves in lead 3. So these are like very peculiar situations where you read about these capital Q waves present. And well, what do you mean by S1 Q3 T3 is mainly the right ventricular strain pattern that is happening in this patient because the clot is occluding the pulmonary artery. So the right ventricle will have to do more work, and more work of the right ventricle can then translate into development of right ventricular strain. So these are abnormalities of the Q wave. So at the moment you learned abnormalities of the P wave, abnormalities of the PR interval, the short versus the prolongation part, and now I'm teaching you regarding that there would be abnormalities of the Q wave. And following this, we'll study regarding the commonest arrhythmia in clinical practice, guys. The most common arrhythmia in clinical practice is not ventricular fibrillation. The commonest arrhythmia in clinical practice is atrial fibrillation. The highlight of this condition will be that when you check out the RR interval, the RR interval of this patient will change every time. Like you can see two large squares, so the heart rate is 150, 300 divided by 2. Then thanks to the vagus nerve, the heart rate is stabilizing to something like a little less than 75. But then it is again moving on to something like, I would say, it's not exactly 3, so it's a little more than 100. So I can put values there like this. Like suppose this is 150, then vagus nerve is trying to bring the heart rate back to normal, so something like 75. And then the heart rate is going down to 3.5, so I'm putting a value of, let me say, 120. So why I'm saying this is because you will always read the word irregularly irregular pulse. Irregularly irregular pulse or variable RR interval is the main catch in a patient of atrial fibrillation, and you can see a twitching activity happening here, which means that there is no P wave also occurring in this patient. So every time you read a statement like this where he says that the person's ECG is showing absence of P wave, and along with this, he will say variable RR interval. Guys, in all tachyarrhythmias, the RR interval will be less because there is a tachycardia, but it will never be variable. Here it is a variable RR interval, and intermittently in this condition, thanks to the vagus nerve which is trying to put brakes, the heart rate can even touch normal as well. Now, I mean, normally in tachyarrhythmias, no, if heart rate is fast, it remains fast only, no? In any tachyarrhythmia that you've read, ventricular fibrillation, if heart rate is 200, it will be 200, 200, 200 like that only. It will never touch normal. A patient will most of the time die, or you have to do intervention, then they'll come back to normal. But atrial fibrillation, you can see, is occurring above the AV node, and AV node is where the vagus nerve is. So you can see the vagus nerve at the moment can apply brakes. Vagus nerve can apply brakes and can try and bring down the heart rate back to normal. That explains like a couple of drugs that we'll be using for management of this patient. And well, why do we have is a development of atrial fibrillation is also what we need to understand. But what you can see in this diagram is that there are multiple ectopic foci, like all these green lines that are drawn in the atria of this patient. These are multiple ectopic foci. These are abnormal foci which have developed in the heart of this patient. How do we pick up that these are ectopic foci, for which we do special study? Can you tell me the name of the special study, guys? Yes, a question to you guys. Don't check out the notes. Can you tell me how do we pick up? Like in ECG, there would be absence of P wave, no? So that's not telling me that there is an ectopic foci. It just tells me absence P wave, tells me SA node is not the boss anymore. This is the SA node. The SA node is afraid. He cannot fire as fast as this ectopic foci. The ectopic foci in this condition fire at a rate of something like 300 to 600 times per minute. These are like, powerful guys. SA node can fire at a rate of max 60 to 100 per minute. And you see, you can't have two bosses in the heart. In one area of the heart, you can't have two bosses. That applies everywhere. No, in one company there can be one boss only. In one house only one person will be dominating. Other people have to follow. And this is how the rules of nature are, or how things should be operating. You can't have two bosses in the same area of the heart. So the guy is more powerful take over, and the SA node will say, "Okay, I'm not gonna fire." SA node has literally folded his hands. He says, "Boss, I can't fire. I can't find with this guy. This is more powerful." So SA node will stop firing. That's why I put a cross that explains why P wave is missing. And because these ectopic foci fire at variable rates, like you can see, they're not firing at a constant rate. It could be 300, it could be 350, it could be like 400, 420, because the rate of these foci also keeps changing. That is why even the ventricular rate of these patients will keep on changing, and vagus intermittently will try to keep on, applying brakes and try to control the discharges. In fact, atrial fibrillation overall, guys, is one of the leading tachyarrhythmias, sustained. Again, the word is sustained. I mean, tachyarrhythmias are not sustained, guys. People die within 4 minutes of a tachyarrhythmia. Either they live because of your intervention of giving a DC shock, or they expire. The person will die. But this tachyarrhythmia could be persistent for long duration. It could be for weeks, it could be months. Sometimes it is diagnosed when person will develop stroke because it could cause clots in the heart. Because atrial fibrillation is one condition, guys, that can, because twitching ho raha na, that twitching can cause formation of clots, and these clots can then go into the brain of the patient. It can cause stroke. So lots of time atrial fibrillation is diagnosed when patient is going to have developmental stroke. The problem in this patient, like at this moment, the query in your mind would be why there is multiple ectopic foci. Why? I mean, question patient's relative will also, his son will also ask you, sir, why is my dad having this abnormal focus? So most of the time you will notice these people were hypertensive. Hypertension is a silent killer. Hypertension causes hypertrophy of the heart. It can also contribute to structural damage to the heart. Long-standing hypertension can contribute to atrial fibrillation. Most of people who are going to be diagnosed with atrial fibrillation in the geriatric age group, guys, this arrhythmia is more common in geriatric age group, and most of them are going to be having like undiagnosed hypertension, or they were hypertensive but were not taking treatment. So now we need to understand, like in these patients of atrial fibrillation, what are the causes. The leading causes hypertension, but it can be like ischemic heart disease also. It can be thyrotoxicosis also. So how to remember the causes of atrial fibrillation? There's a mnemonic. The mnemonic is called as HINTS. So let's just work it out. The first one to be remembered is hypertension. You see, hypertension causes LVH. On X-ray, there's a cardiomegaly, left ventricular hypertrophy. But after left ventricular hypertrophy, they will develop as left atrial hypertrophy also. And what I mean by left atrial hypertrophy is that there is going to be ultimately a structural damage to the left atria. And whenever we have structural damage to the heart, it can trigger abnormal current. And this abnormal current is in the form of ectopic foci, which could be firing at very fast rate and could be contributing to tachycardia and tachyarrhythmia in a patient. Then is ischemic heart disease. I mean, what I'm saying is this patient was having triple vessel disease. So I had advised him, I had told him, sir, because you are having triple vessel disease, so we suggest that you undergo coronary artery bypass grafting. Or suppose it was double vessel disease. So I told him, sir, you should go for percutaneous coronary intervention with stenting. So patient said, yes, sir, but did not get it done. So you know that most people in India, when they are afraid of getting a CABG or stents in the heart, then these people can end up with ischemic cardiomyopathy. And again, the common thing with ischemic cardiomyopathy and hypertension is damage in the heart, and the structural damage will trigger an arrhythmia. Then can be toxins. Alcohol causes dilated cardiomyopathy. If you listen to the cardiomyopathy part, I've said dilated cardiomyopathy. In fact, he could say this alcoholic, he went to on a holiday and he drank himself to death in dilated cardiomyopathy. Like this guy, he drank so much. When he will drink so much, what will happen is that the vagus nerve will be suppressed. You see, the alcoholic, he went to a party. And in the party, he drank a lot of alcohol. When you drink too much of alcohol, then the vagus nerve, that is the natural brakes in the heart, will fail. Remember, I showed the brakes in green. These brakes were the one which were trying to control the impulses from going in the ventricles. Now, if the brakes will fail, all these impulses will go down and this guy's BP will crash, because when the heart will beat very, very fast, then input in the heart, because if heart will beat very fast, it will not get time to relax. If input is less, output will be less. And therefore the person can die. That is why we read the word holiday heart syndrome. The most common cause of death in holiday heart syndrome is the topic that we're studying, guys. Atrial fibrillation can contribute to death. Binge drinking is always dangerous in alcoholics. Why we discourage them for binge drinking? He says, no, I get a high from it. And this guy's wife, when he went for that party, she was saying, no, don't drink. Doctors advise you not to. But when he went to the party, like his friends, nasty ones, they said, oh, no, abhi to party shuru hua. Thoda sa pilo. And they made him drink like 3 drinks in 1 hour. The guy subsequently died. That is because the presentation is called as holiday heart syndrome. Then can be thyrotoxicosis, because thyrotoxicosis, thyroid hormones have an intrinsic sympathomimetic drive. Thyrotoxicosis causes a sympathomimetic stimulation that causes hypertension. And hypertension again contributes to damage to the heart in the form that I've shown. So structural damage will explain atrial fibrillation. In India, one of the causes for atrial fibrillation is also rheumatic heart disease with mitral stenosis, because it will cause a left atrial enlargement, and this structural damage to the left atria can then trigger an arrhythmia. So like in abroad, usually the causes are like, in India also, causes of hypertension. Why I'm saying India, rural India, right? Rural India. In rural India, like you will have rheumatic heart disease more common due to sore throats. So a rural Indian patient when he was a child, he was having rheumatic fever. And subsequently, at 25 years of age, he had mitral stenosis, for which maybe even he required valve replacement surgery. So these people who are having that left atrial enlargement, because he required a valve replacement surgery like a prosthetic valve, and patient did not get it done. You see, if we tell a patient, sir, your heart valve is damaged and surgery is required, if person will not get it done, then the poor heart is structurally damaged. It can trigger this arrhythmia. So even if he says what is the most common sustained arrhythmia in hypertrophic cardiomyopathy, the word is sustained. No other tachyarrhythmia can be sustained. It will kill the patient in 4 minutes unless and until you do cardioversion or give drugs to the patient. Even in hypertrophic cardiomyopathy, guys, the answer is given as atrial fibrillation. That is a separate aspect that when you listen to the cardiomyopathy section, I've told a young guy playing football and he's running after the ball fast and he collapses on the football pitch and dies. If it's gonna be the word sustained not written, he just says what is the most common cause of sudden cardiac death in hypertrophic cardiomyopathy. I'll do a color change to highlight the importance of this MCQ as well, because in all other conditions that I was describing, it was only atrial fibrillation, but here the answer would be given as ventricular fibrillation. So do take care of the fact that in a hypertrophic cardiomyopathy question, is he asking you the word sustained tachyarrhythmia, or is just saying the word patient is running after the ball fast, collapses on the football pitch and dies? The cause is ischemic ventricular fibrillation. In all questions on atrial fibrillation, the buzzwords will be irregular pulse, and will say the word absent P waves in a client or a patient with tachycardia. I mean, that's the key words that you to identify reason for irregular. So many foci, too many bosses making a mess. Each one of doing, I'll do faster. Other ones say, oh no, I'll do more faster. And because there are too many bosses right now, the problem, one boss. Now there are so many bosses. Each one is trying to outdo the other. So everyone is trying to do a faster rate, and therefore in these patients you'll have a variable pulse, you'll have a irregular RR interval, and on basis of this we can do a question that came in the paper. Like he said, a 50-year-old hypertensive patient is having palpitations, and along with that he's having dizzy episodes for past 1 year. Like he says, like I'm sitting on a chair and I feel, sir, I'll fall down, so I just keep sitting on the chair for like couple of minutes, then I feel better. And like his son also told him, that, or his daughter told him, why don't you go and see a doctor? So like most people in India like this, no, I'll go to doctor. He will write so many tests. So he did not come for any examination. For 1 year, he has been suffering. But so no doctor will write so many tests and they'll charge money and everything. And he kept on bearing that. Now, when he came to the hospital at the moment, because it became too much for him, 200 was the heart rate. And there was an irregular rhythm, because whenever you check the pulse, first you check the rate and then you check the rhythm. So rate was 200 and it was irregular rhythm. BP was elevated because he's anyway hypertensive. Lungs are clear, that's okay. ECG shows absent P wave. So you can see one, the risk factor is present, hypertension. The key word in the question is irregular pulse. As I've told you, that is one of the main features for this condition. ECG shows absent P waves with the irregular RR interval, and he's also showing a dangerous thing. Echo of the patient shows left atrial appendage clot. This guy is literally, like, guys, I can say this is like this guy is literally sitting on a time bomb. Why I'm saying this guy is sitting on a time bomb is because these clots can go, this single clot or multiple clots can go out of the heart to the brain, and this guy will start developing face deviation, arm deviation, leg weakness. Acute ischemic stroke can occur in patients of atrial fibrillation. I repeat again, a patient of atrial fibrillation is literally sitting on a time bomb. When that bomb will explode, nobody can tell. It can be today, it can be tomorrow, it can be after 5 years. But when that will explode, that is when family members will say, oh sir, if we knew earlier, no, we would have intervened. The point is, there's no point crying over spilt milk. Most people are already aware something is wrong with them, right? And most of the time, because of like this, what people think is the doctors write unnecessary test. I agree to that. They might be black sheep and a lot of us might be doing this wrong thing also. But usually, like, if you're doing, like in India, there is so much of work, right? Ethical work, that there is no need to do unethical work. So, but I mean, they're obviously black sheep, so they can be problems. But like this guy, as I said, can end up with acute ischemic stroke. So he gave a case like this. He said, like, what is the first line management of this patient? So what we need to do is decrease the heart rate of this patient from 200 back to 100. We need to go for rate control ways. Every time there is a arrhythmia present, first thing is a rate control. Get the heart rate back to normal. That will help in, make him feel better. 200 is just too fast. So what we do in these patients is use beta blockers. The drug of choice for rate control in these patients is like beta blocker, like esmolol can be given, that is intravenously, that will help in like stabilizing the heart rate of this patient. And then subsequently we will have to put this patient on the anticoagulation drugs also. Anti-clotting drugs can be like a apixaban or rivaroxaban, that can be done in this patient. So for rate control, which is the first line management, it is esmolol which is to be used. Now at this moment, I also want to bring to your attention that beta blockers are the preferred molecules for rate control in atrial fibrillation, but there are two contraindications to beta blockers, and these contraindications are ones which they love to ask in the exam. One of the contraindications is obviously asthma and COPD. You very well know beta blockers should not be given in asthmatics and COPD patients because it can cause worsening of their asthma or COPD component, even if it is cardioselective, even then. And the second point I want you to remember is that beta blockers are contraindicated even in acute heart failure. If a person is having acute pulmonary edema, then we are not supposed to use beta blockers. Acute pulmonary edema, beta blockers are contraindicated. Why? Because in pulmonary edema, fast beating of the heart is the saving mechanism. In pulmonary edema, the heart will beat faster to clear the pulmonary edema. Now, if the pulmonary edema part is not cleared, person will die. So there was a question, a variation of this that was asked in NEET PG, and look at that question. Now a variation of the same question that was asked in NEET PG said a 50-year-old patient with hypertension is having palpitations and dizzy episodes for 1 year, identical lining. On examination, the heart rate is 200 with irregular rhythm. That tells me he's still talking about atrial fibrillation. BP is elevated. That's because he's hypertensive, though later can fall also, because when the heart will beat so very fast, then the time available for relaxation would be less. Input is less, output can crash. But the main thing that is given in this question is this auscultatory finding of bilateral crepitations. I mean, every time you read about crepitations in the chest, it tells you that the person is going into heart failure, is going into pulmonary edema, and hypertension causes stress on the heart, so that can contribute to pulmonary edema. This question is on atrial fibrillation. There is absent P waves with the irregular RR intervals. So I am not worried about like what is the diagnosis. Even the echo is showing presence of left atrial appendage clot. So the guy can end up with stroke also. But at the moment he's saying what is the correct management. So I have deliberately removed one option. Obviously the answer is not esmolol, because that I've told you in my previous slide that esmolol is contraindicated in patients who are having presence of congestive heart failure. But then the point is, what drug would you use in this patient so that you can stimulate the vagus nerve also, and at the same time control the heart failure findings also, because vagus is important to put on brakes and control the heart rate, and at the same time I need the drug to increase the cardiac output also. Well, the answer of yours would be answered as digoxin. Yes guys, digoxin as a drug, what it does is, and obviously the drug would be used intravenously, we'll have to give a loading dose followed by maintenance dosages, but what digoxin can do in this particular scenario is that digoxin acts on the vagus. So that will help in controlling the heart rate of the patient, and at the same time it has a positive inotropic action. Like you always read that digoxin has a negative chronotropic action. How does it have a a negative chronotropic action is vagal stimulation, and at the same time it has a positive inotropic action. So there are double advantages that I'm getting at the moment. Positive inotropic means increase the force of contraction, that will help me clear the pulmonary edema, and the vagus stimulation would help me control the heart rate of this patient. We don't use adenosine for these patients, so that anyway would be ruled out. Adenosine is used in PSVT, atrial fibrillation. Rather, adenosine can even worsen the case. And as far as cardioversion in this patient is concerned, cardioversion is done in hemodynamically unstable patients. Like if the BP was unrecordable, or it is like 80/60 or turning out to be very, very low, then I can think of it. But even then, if I plan to do cardioversion, first I need to do anticoagulation, because otherwise the clots can go in the brain also. So all other options can be ruled out. And the main thing that you have to understand is that in a person who's having heart failure, you are not supposed to give a beta blocker. You are supposed to give digoxin for management of this patient. And now let's look at another version of the same MCQ that was asked the preceding year in again NEET PG. This time, however, he changed the age group of the patient. He said thyrotoxicosis leading. So like you thinking Graves' disease, is having palpitations and dizzy episodes for past 1 year. Currently, our heart rate is 200. I've kept the vitals almost the same to give like similarity between the previous question. Like you can see, pulse rate is very high. The blood pressure is also elevated because thyroid hormones causes sympathomimetic stimulation. So that's why the hypertension component can be present. She's also an asthmatic, and the ECG shows absent P wave with irregular RR interval. So I know it is still a question on atrial fibrillation, but there is asthma given, and that immediately tells me that I'm not supposed to use a beta blocker in this patient. He's asking what is the correct management of this patient. So what I will use is a calcium channel blocker. The calcium channel blocker I can use is like verapamil, or I can be using diltiazem, but I cannot be giving esmolol because that can worsen the asthma component of a patient. So you can see the couple of variations of the same question that have come up. Most of the time, like for rate control, whenever they ask you for, first thing is rate control anyway, because if somebody comes to me with a heart rate 200, I need to decrease it to make him feel comfortable. Beta blockers are not given in acute pulmonary edema. How was it given in the question, the crepitations part, or you can mention poorly controlled asthma, then the answer will change. For like congestive heart failure findings, it is digoxin that would be used, and if it's gonna be asthma, it is verapamil that is used. Now, the algorithm for management of long-standing atrial fibrillation. What I mean by long-standing is like more than 48 hours. The first thing to be done is always the rate control, and we need to give esmolol. Instead of esmolol, we can also be using a drug like verapamil or diltiazem. So you will notice that calcium channel blockers can be used in these patients as well. So any of the two drugs can be used. But if, let me say, CCB is also given and beta blocker is also given, then short-acting beta blocker like esmolol is one of the short-acting. I said not shortest. I said it is one of the. I said it is one of the shortest acting beta blocker. So esmolol can be used in a hypotensive situation. Otherwise, it is a calcium channel blocker. Though I told you that if it's gonna be acute congestive heart failure, then even digoxin can be used. Then as far as anticoagulation is concerned, how do I know it is anticoagulation required for a patient or not? Well, one is evidence from transthoracic echocardiography, because that can show evidence of clots usually present in the left atria of the patient. So echocardiography can tell me. Or I will subsequently be telling you about a score. Now, the full form of the score will be discussed subsequently, that is CHAD S2 VSC score. But I just want to say that if the mathematical score is more than 2, the parameters will be discussed in a while. But if it is score more than 2, then it helps me in deciding the need for oral anticoagulation in this patient. And well, one of the anticoagulants that I will use is warfarin. But warfarin is to be given only in Indian patients who are having rheumatic heart disease with mitral stenosis. So he will say the word VAF, valvular atrial fibrillation, that is rheumatic heart disease with MS. But if he says the word non-valvular, that includes all other conditions: alcohol, dilated cardiomyopathy, restrictive cardiomyopathy, ischemic cardiomyopathy, thyrotox. I mean, all other situations, whenever it is present, non-valvular atrial fibrillation, then we should be using the newer oral anti-clotting drugs. That is novel oral anti-clotting drugs. Here he will ask you about medicines like apixaban, or we can use rivaroxaban, or we can use dabigatran. So the medicines, the newer medicines, anti-clotting drugs, would be quizzed by you by the examiner for management of prevention of embolic stroke. This is for prevention of embolic stroke in a patient. Miscellaneous question that came in the paper, this was like an FMG exam question. He simply said, why do you use apixaban in this patient? So you have to prevent the development of stroke. And like in the options, he said like which drug would be used, and that's going to be like a apixaban has a X in it. So from that you can pick up that the drug that is used at the moment, this would be a factor 10 inhibitor. Alphabet X is what I put here. So this is like a factor 10 inhibitor that I've said. And then dabigatran is like a direct thrombin inhibitor. It has an alphabet T here that I'm not writing because you know that from pharmacology also. So just wanted to say that in some questions they try to incorporate a bit of basics of pharmacology as well. Factor 10 inhibitor versus direct thrombin inhibitor. First we do rate control, then we do anticoagulation, then we plan for chemical cardioversion. Chemical cardioversion basically means rhythm control, that all the bad guys in the heart. Remember, his heart was having that multiple ectopic foci, so we need to put brakes on them. So to suppress all those ectopic foci and to put brakes, I need to go for rhythm control. And for this, we will be securing an IV line and give this medicine to this patient by the name of amiodarone. Amiodarone is used for ventricular tachycardia also, and is used for even atrial fibrillation. So I can call it like a broad spectrum antiarrhythmic drug. Amiodarone is the drug of choice for stable ventricular tachycardia, that you know even from your pharmac classes. I am saying it can be used even in management of atrial fibrillation. So it's used in ventricular and supraventricular tachycardia both. And this will help me in getting the P wave back to normal because it will suppress the bad guys. But suppose if the chemical cardioversion fails, and like I have given the injection, the P wave is not coming back to normal, the irregular RR interval is not stabilizing, then I can go in for electrical cardioversion in this patient and deliver a DC shock to this patient of 200 joules intensity. I would like to clarify here that I must do anticoagulation in this patient initially for at least 6 weeks, and only after that I should be trying the subsequent steps. So the initial management is like emergency management is rate control, and start the patient on anticoagulation. After 6 weeks in these patients, when we have taken care of like the clots in the atrial appendage, then only the step number 3 and like step number 4 is to be done. So anticoagulation, this is not like I start the medicine today and I can go for the next steps. Like these steps are to be remembered as RACE, RACE. Let me just mark out the mnemonic for this. I mean, that's a algorithm for management of long-standing atrial fibrillation is RACE. Alphabet R is for rate control, A is for anticoagulation, chemical cardioversion, and electrical cardioversion. It is over a period of time that you'll be doing these activities. First is rate control, then is anticoagulation for 6 weeks, then is chemical cardioversion, and then is electrical cardioversion. That's the RACE algorithm for management of long-standing atrial fibrillation, which means like the atrial fibrillation has been persistent for like more than 48 hours. It could be like 1 week, it could be 2 weeks, or it could be 1 year. Nobody knows when did it start. But if he talks about recent onset atrial fibrillation, if he specifically mentions, now especially if you're an FMG student, pay attention to the statement. This is what they asked in your exam: recent onset atrial fibrillation was given in the question. If it's a recent onset atrial fibrillation and it's causing a hemodynamic instability, there is no clots in the atrial appendage, then if the BP of the patient is unrecordable, then I'll not waste my time giving medicines. In any arrhythmia, in any tachyarrhythmia, if the BP is unrecordable, if he says the word hemodynamic instability, or if he says the word crashing patient, then I'm not going to waste my time and do all the tham jam that I was saying earlier. In a crashing patient, I need to act fast. So if he says, what will you do in this case, your answer will be given as directly a cardioversion. So RACE protocol is only to be answered in those situations when it is going to be like a long-standing atrial fibrillation. If he says the word recent onset, previous 48 hours, and we did echo, there is no evidence of any clots, then straight away cardioversion can be done. What I mean by cardioversion is it would also be called as synchronized. Cardioversion is also called as synchronized DC shock. What I mean by the word synchronized is that the computer will fire the impulse at the peak of the R wave. Non-synchronized DC shock is like the computer will fire without the peak of the R wave, but here it will search for the R wave, and there are R waves present in the ECG. So after the peak of the R wave, the computer will fire this impulse. I'll teach you in a while when do you use non-synchronized DC shock, but at the moment for atrial fibrillation, for both varieties, whether it is like long-standing or recent, it is DC shock, that is synchronized DC shock that should be used. So I'll just add this word here as well, so that you can remember this. Electrical cardioversion that we are always doing is synchronized DC shock. I'll teach you subsequently when do we go for non-synchronized DC shock in a patient. And now we can remember the full form of the CHAD S2 VSC score, where C stands for congestive heart failure. Simple English, C stands for heart failure. Okay, let me write it down for practice. H is for hypertension, A is for age of the patient, and you will notice that the age part will come 2 times. I'm putting a star here to say that you can notice if age is more than 75. This atrial fibrillation arrhythmia is more common in geriatric population, and if it is more than 75, it is 2 marks. If the age of the patient is 65 to 74, it is 1 mark. Why that is important is normally in a classification or like in a score, one parameter is always taken once, but here the parameter has been taken 2 times. Like if age is more than 65, 2 marks. If it is going to be 68 to 74, it is 1 mark. And then you will notice that D stands for diabetes mellitus, and S2 is given as 2. Why? Because of the fact that the person has previously already had a history of stroke. So especially for this score, what you need to remember is obviously the full form, but you also need to remember regarding which parameters are having 2 marks. One is prior transient ischemic attack or stroke, like he's already had a stroke event, then there is more chances of him having a second episode. So that's why like 2 marks are being given. It is prior, mark my words there. We're talking about the current scenario. We're talking about he already had a stroke or he had a transient ischemic attack. Now TIA is what I discussed in neurology section. I'll just say verbally at the moment. TIA is mini stroke, where the symptoms will resolve within 24 hours, but stroke, the symptoms are not going to resolve. And then VA is like a vascular disease. Vascular disease could be like aortic plaque, myocardial infarction, peripheral arterial disease. And SC stands for sex category being female. For example, if it's a male patient, we give 0 points. If we say female patient, it is 1 point. And the full form, I'll say that fast again: congestive heart failure, hypertension, age, diabetes mellitus, stroke history. VA is vascular disease like previous MI, aortic blocks, atherosclerosis, like that. Then is age once again, and SC sex category. If the score turns out to be more than 2, if the final score of the patient is more than 2, then it is need for anticoagulation. He simply has asked in the exam, CHAD S2 VSC score is used for, that I've already sensitized you. Need for oral anticoagulation in an arrhythmia by the name of atrial fibrillation. That's the only thing you need to remember. Even like they would unlikely to ask you like score more than how much. They'll ask you only one thing, that why is it used? That is to decide the need. On this, the query most people is, sir, you had echocardiography now, so why do you need this score? By echo can pick up a clot only if it is more than 2 millimeter. If the clot is chotu 0.2 millimeter, 0.5 millimeter, then echo is blind to that. Just like a radar, no, radar can pick up a plane of a particular size. If the plane is very small, if the plane is flying below the particular level, radar cannot pick it up. Similarly, if the clot is very chotu and is not visible, that does not mean that it is there. So these risk factors indirectly tell me that yes, there is a need for anticoagulation even if the echocardiography is normal. And in some patients anyway, they're literally sitting on a time bomb that the clots are present in their atria. Now we will study regarding a cousin brother of atrial fibrillation, that is called as atrial flutter. Atrial flutter as a condition is characterized by an abnormal circuit. This abnormal circuit that I'm showing before you, there is a single abnormal current in the right side of the heart. Unlike in atrial fibrillation, where I was teaching you that there are multiple abnormal currents in the heart, like in atrial fibrillation, I'll just show you the slide. There were multiple these abnormal currents in both the left and the right atria. You can see multiple ectopic foci is what I had said. This time what I'm showing before you is a single abnormal circuit in the heart. The technical word for atrial flutter will be answered by you as that this person would be having is a presence of macro re-entrant circuit. So one is the re-entry current word I want you to be used to, and second you'll say the word macro re-entrant circuit in the heart. I mean, this is an abnormal current, and this abnormal current is circulating in the right atria of the patient. Let me just write it down and then I'll clarify further. Atrial fibrillation is having multiple ectopic foci, and here it is macro reentrant circuit. I also put up a question that how do we know that these ectopic currents are present in the heart? Then the special test that we do is called as electrophysiological studies. Whenever you go into cardiology department, one, you will always notice there would be cath lab where they'll be doing like vascular interventions and they go into the coronary arteries, and then there's a separate lab where they do electrophysiological studies. These electrophysiological studies help us determine where is the abnormal circuit in the heart, whether it's like multiple foci in the left and right atria, or there's like a single re-entrant circuit which is causing activation of the AV node again and again. This time it's a macro re-entrant circuit in the right atria of the patient. Most of the time, the location of this also can be asked to you. So I'll be more specific where in the right atria. So in the right atria also, it is located at the cavo tricuspid isthmus. What I mean by cavo is that where the superior vena cava and IVC finally will drain into the right side of the heart, and close to the tricuspid valve, that's where posteriorly like the great veins would be draining into the right atria. So macro reentrant circuit in the cavo tricuspid isthmus is the reason for generation of this arrhythmia, and the firing frequency of this ectopic focus would be something in the range of 250 to 350 times per minute, unlike in atrial fibrillation where the ectopic foci were firing at like range of 300 to 600 per minute, and there were multiple foci, many guys trying to be a boss. This time it is only one boss, but then he's more powerful than the SA node, and his electrical activity will generate these special waves, and these special waves is what you are already aware of. They don't look like P wave. They neither are satisfying the height and the duration criteria of the P wave. They're much more spiked, they're much more taller, and they have a configuration which is different from our P wave look, and they're called as sawtooth waves. So most of the time atrial flutter would be an easy question for you because examiner himself will mention regarding the presence of sawtooth waves. The question then arises, what will he ask? That I'll explain on my next slide, but there are two concepts which I want you to be clear on this particular slide. First, how do we know where is the abnormal focus? Is it in the atrium? Is the abnormal focus in the ventricles? Is it at the junction of the atria of the ventricles? How is the current flowing? We do special studies that is called as electrophysiological studies. That is point number one. Point number two to be remembered is that this abnormal circuit called as macro reentrant circuit in the cavo tricuspid isthmus located in the right atria of the patient will be ultimately responsible for sawtooth waves, which do not have the configuration, the height and the duration criteria. The P wave is not satisfied. Now let us look at what will he ask then for this particular arrhythmia where sawtooth waves are mentioned by the examiner himself only. This is an ECG representation at the moment, and the person is not even having tachycardia. But at the same time, I still need to fix the problem because at the moment, like the heart rate is pretty decent, but then it can accelerate subsequently, or there could be clots formation. Even in these patients, clots could be developing in the heart and they could be going in the brain. And as far as the risk factors are concerned, guys, the risk factors for these patients are almost the same. Whether I say atrial fibrillation, whether I say atrial flutter, the risk factors are almost the same, but I would like to add one additional risk factor, especially for atrial flutter, that would be like COPD. Though COPD can contribute to even atrial fibrillation, but I would say that in COPD patients, right side of the heart is more commonly involved. No, COPD causes pulmonary artery hypertension. So a hint in the question, like I was saying, for atrial fibrillation, he'll usually begin by saying alcoholic, went to a party, did binge drinking, then he collapsed, and then unfortunately expired. That is like holiday heart syndrome. Here it could be a COPD patient who's having developmental complaints of palpitations and even syncopal episodes that have occurred previously. The COPD is not a feature that will diagnose this condition, guys. I would like to make it clear. It is just that, sometimes in questions they have this peculiar habit of mentioning alcoholic patients, hypertensive patients. Like for atrial fibrillation, I was very particular about hypertensive patient. It can be or hypertension or alcoholic patient. Similarly, examiner is usually like using COPD patient with palpitations and dizzy spells, or is causing recurrent syncopal attacks, and after that he'll say currently he's not having any problems, but he has come to you because he's having this on a recurrent basis. And when you're scanning the heart rate of this patient at this moment, the heart rate is doing pretty fine. In fact, there's a possibility that this guy may be on treatment also, because of which the heart rate is like doing 50 at the moment, or there could be a compensatory vagal discharge that is increased in this patient. One possibility why the ECG is doing normal is maybe he's on medical management. Second possibility is that his vagus is doing extra discharge, trying to control the heart rate of this particular individual. So the examiner will himself mention the word ECG shows sawtooth waves. If it does not, you can still pick it up. I mean, just look at this peculiar configuration of waves which are present. I mean, the way they are shown, they look like jagged edges of a saw. So sawtooth waves is a ECG finding which is to be remembered. And now comes the question. I mean, he will ask you, what will you do for management? For management of this condition, the algorithm is same, guys. It is still RACE, that is to be used for long-standing atrial flutter. The first thing to be done in these patients in this long-standing atrial flutter would be rate control. The same data is valid. Esmolol is preferred. If it is an asthmatic, I would not like to give esmolol. I can then give calcium channel blockers. I'll write both of them at the moment, like esmolol, diltiazem, verapamil. There I wrote verapamil, this time I wrote diltiazem. Doesn't matter, it's after all calcium channel blocker that can be used. Even these patients will require anticoagulation. High risk of clots even in these patients, especially going in the lungs, because I said COPD patient and the clots in the right atria, they could land up in the lungs. So anticoagulation needs to be done. So I'm writing OAC, that could be like warfarin or the newer drugs that I mentioned. Then after we have taken care of the clots and echo is giving us a clearance, even CHAD S2 VSC score can be used in this patient. We will now go for rhythm control. Rhythm control will mean that we'll give a medicine that will suppress this macro reentrant circuit, and the medicine we can use is amiodarone. So you can see that amiodarone can be used for both ventricular tachycardia, atrial fibrillation, and now atrial flutter. At this, the query of most people is then what is the difference, sir? You said the same thing for even patients of atrial fibrillation, but you said it's going to be different. So difference is that in this case, the DC shock that is given is of low intensity. Guys, because here it's only a single focus, no? Not multiple foci, so we need to use less power. So most of the time the question that will come on this topic usually tends to say that in which tachyarrhythmia a DC shock of 25 to 50 joules is used. This is the lowest intensity of DC shock that I will be explaining to you ever in the cardiology section. Low intensity DC shock is used for management of atrial flutter is the statement that I want you to remember. This would obviously be a synchronized DC shock. So at this moment, an additional question can be worked up, like in which conditions will we be answering non-synchronized DC shock? Then your answer would be only two arrhythmias. Do you go for non-synchronized DC shock? That is ventricular fibrillation and pulseless ventricular tachycardia. Apart from these two, it is always going to be answered as synchronized variety of DC shock. Both data have to be remembered. For all tachyarrhythmias, whether I name it or I don't name it, atrial fibrillation, atrial flutter, PSVT, like I've named them at the moment, it is always a synchronized variety. But if he says non-synchronized DC shock would be given for, then the answers are ventricular fibrillation and pulseless ventricular tachycardia. Then this non-synchronized DC shock is also called as defibrillation. What I mean by the word non-synchronized is that now the computer will not search for the R wave, it will directly deliver a DC shock. Whereas in synchronized, I mean, these are technical aspects that they can ask you, sync mode versus non-sync mode. Now on this slide, I'll make you revise some of the concepts that we have already studied on the previous ones. You see, if you check out the RR interval of this particular case, the RR interval is turning out to be variable. I mean, when you scroll from left to right, the distance between the R and the R waves is changing, and there is absence of P waves also. So I don't need to write that there is absence of P waves. This we have already discussed as atrial fibrillation. What I wanted to draw your attention to the fact is that in the paper they've given an ECG in which the RR interval was once again variable. Like if you check out the RR interval at this moment and then compare this with the RR interval at this particular junction versus another one subsequently, you can notice I've not written the mathematical numbers, but I can say that on a visual scale also, you can check out that the distance between the R and R is changing. Now on this, the impression is that this is atrial fibrillation, but then when you look inferably, you can still see the P waves present, like here P wave is present. You can see that P wave is once more present, but even is having a bigger size in contrast to, I can say, a P wave, which is almost very small in the subsequent complex. So what I am trying to teach you guys at the moment is that the moment you read about irregular RR interval, obviously you need to set the alarm bell ringing in your brain for atrial fibrillation. But there is one more arrhythmia that I'm adding to your knowledge base at the moment, which can have a irregular RR interval. The difference of this from the previous one is that in this one, the P wave would be present. And you will also notice that the P waves will be having variable height and variable duration, that is a variable morphology. So the second ECG, which has been shown in light blue color, is that of multifocal atrial tachycardia. The superior one is AFib, that already has been discussed with the RACE algorithm. Now a new data has been added to your knowledge base, that is called as MAT. The full form of MAT would be multifocal atrial tachycardia. Even this arrhythmia is more common in COPD patients. So two questions where I've said like the examiner usually begins by describing, not that that's like a diagnostic feature, no, I'm not saying that, but two questions where I've usually seen examiner begins by saying COPD followed by palpitation, syncopal episodes, is one atrial flutter discussed prior to that, and second is MAT, multifocal atrial tachycardia. Well, how would you differentiate? In atrial flutter anyway, you will be able to identify these sawtooth waves which are already highlighted and was discussed a couple of seconds to minutes earlier. But then an additional point I've added is MAT would be having variable RR interval, irregular RR interval, comes two times in medical vocabulary. So let's just put markings here to remember this information. Two medical disorders where you always read about irregular RR interval is atrial fibrillation, but the discriminatory factor for this one would be in the superior ECG, the P wave is turning out to be missing, and in the inferior one, the P wave is present but is having a variable morphology. So the differentiation is what I tried to explain to you. Also, for management of atrial fibrillation, there is a complete algorithm that we use by the name of RACE. Also for atrial flutter, there's a complete algorithm by the name of RACE. But for multifocal atrial tachycardia, the examiner says, or like the textbook says, that the main treatment is treat COPD effectively, because this arrhythmia is usually due to hypoxia, which is caused by improperly treated COPD. So the main management of multifocal atrial tachycardia is to treat the cause. Yes, for symptoms in this patient, if he says what will you use for rate control, then your answer would not be given as esmolol. You will be answering calcium channel blockers like verapamil or diltiazem. Unlike for atrial flutter, where I said you can straight away answer as esmolol. That's a separate issue. Like if I say atrial flutter with COPD, then it is esmolol. It's not esmolol anyway. But then generally speaking, like for atrial fibrillation question, it is esmolol. Contraindications to esmolol still hold. But I wanted to bring to your attention that in multifocal atrial tachycardia, it's mainly a COPD patient who's having hypoxia in the heart, and that hypoxia is the trigger for this arrhythmia. So he says treat the COPD component effectively. So what I will also do in this slide is just mention regarding what do we do for management of COPD. I'll be teaching you COPD in the respiratory section, but here I have to speak about it because one of the triggers for development of this is the hypoxia triggered by long-standing chronic obstructive pulmonary disease. So to treat the hypoxia, we give LTOT. LTOT stands for long-term oxygen therapy using a nasal cannula. We'll ask him to purchase an oxygen concentrator, and then we give him oxygen with help of a nasal cannula, plastic transparent nasal cannula, which would ensure that the oxygen concentration in the body tends to increase, especially the dissolved oxygen. We will also be giving LAMA in this patient. LAMA would mean a molecule like tiotropium. Then we will also use LABA in this patient. LABA can be like once a day. LABA, can you tell me once a day LABA, please? Yes, guys. Tell me a beta-2 agonist molecule that needs to be given only once a day. And don't check out from the notes. You should be knowing from your pharmacology knowledge, right? LABA that can be given once a day is like indacaterol. Like formoterol needs to be taken twice a day. It works for 12 hours. Indacaterol works for 24 hours. So it's LABA indacaterol that can be given. And along with that, we'll give inhaled corticosteroids. So you look at the surprising thing. I'm teaching you cardiovascular system, I'm teaching you an arrhythmia, but I'm teaching you treatment of COPD. Why? I could have done that earlier also, but mainly because MAT is mainly associated with COPD. So he says there's no rule of giving DC shock also. I did not say DC shock is contraindicated. I said he says there's no rule of giving DC shock. Why does he say that? Is because even if you give DC shock, you terminate the arrhythmia, it will come back again because COPD is prevalent. So he says treat the cause. I mean, in all of them, the cause needs to be treated. Hypertension needs to be treated for atrial fibrillation, but nowhere I was so vocal about like treating the cause. I was like mainly treating the disease manifestation rather than treating the cause. But here he emphasizes the fact that primary treatment of this multifocal atrial tachycardia is reduce the severity of hypoxia. Otherwise, it has a high tendency to reoccur. And the discriminatory feature between the two is common finding between the two is irregular RR interval. You can see the common finding between the two irregular RR interval shown in both of them. The differentiating feature is absence of P wave and variable morphology of P wave. Now we discuss another case scenario where a patient is hypertensive, is coming to me with the irregular pulse. So I know it's a question on atrial fibrillation considering the risk factor of hypertension, but then he mentioned regarding a pulse deficit and the JVP findings. So let me explain what I mean by the pulse deficit first. You see, while you are sitting comfortably on a chair and listening to me, your pulse rate would be like 75 beats per minute. And if I do a auscultation of yours, and I listen to your heart sounds, then your heart sounds would also be 75 beats per minute. I mean, in a normal person like you and me, the pulse rate and the heart rate will always match. If your heart is beating 75 beats per minute, your pulse rate will also be 75 beats per minute. However, sometimes if I don't do the counting properly, like there's a possibility that I'm doing a counting of your pulse rate casually, so I might be actually treating 2 beats as one. And if I count 2 beats as one, they can be different. It could be like, I might say, oh, your heart rate is 73 beats per minute. By auscultation, it is 75, but by palpation, it is 73. So there can be slight deficit. That slight deficit that I'm saying is called as pulse deficit, and pulse deficit can usually be less than 10 beats per minute. I repeat my statement. The heart rate and pulse rate of a person ideally is equal, but there can be errors of counting, and because of errors of counting, 2 beats can be counted as one. So in a normal person, the pulse deficit would always be less than 10 times per minute. But if it is a substantially high value of 20, it indicates that this person is having an arrhythmia by the name of atrial fibrillation. Though I could solve the question by the first line itself. I could solve the question from the first line itself. That is, this is a question of atrial fibrillation. I decided to just add a point to your vocabulary that pulse deficit of more than 10 is considered to be significant and is a feature of atrial fibrillation. And this question was actually a two-step question. He said, what is the JVP finding? The JVP finding of atrial fibrillation would be presence of an absent A wave. So let us just put on the correct perspective what are the points that we have tried to study in this particular MCQ. First is what you already know. Absence of P wave is a feature of atrial fibrillation along with irregular pulse. So nothing new introduced there. But then at the same time, the additional point that was added was that in atrial fibrillation, because there is a twitching of the atria, so the first wave of the JVP is also missing, that is A wave is absent. And an additional point that was added was that when it comes to atrial fibrillation, the question can also mention a word pulse deficit. Pulse deficit means that the heart rate and pulse rate will not be matching at all, because if the heart is beating very fast irregularly, then this will cause more errors in counting. I said fast beating heart anyway can cause errors in counting. That is one. And second is if it's an irregular rhythm, then you might be mistaking 2 beats as one, and therefore there would be more discrepancy present as compared to what is present in a normal individual. So two additional points have been added to your vocabulary, that atrial fibrillation has absence of the first wave of the ECG as well as first wave of the JPP and has a significant pulse deficit. Remaining options are anyway, I mean, this would not be A option is funny, absent P wave. Canon A wave is what you see with respect to ventricular tachycardia. I've discussed that in the JVP section, that we read about Canon A waves in VT, ventricular tachycardia. We also read it in a complete heart block, and I described the ECG of the complete heart block earlier to you, where P waves and R waves were not matching, that is Stokes-Adams syndrome. And steep X and absent Y has been discussed in the JVP section for cardiac tamponade. So what I've also tried to do is make you revise some of the data which has been discussed already. We'll talk about an arrhythmia by the name of PSVT, that would be paroxysmal supraventricular tachycardia. Let's look at what is the problem in these patients. This time there is a re-entry circuit, and this re-entry circuit is present around the AV node of the patient. You see in the previous discussion, that is atrial fibrillation versus atrial flutter, the location of the ectopic foci was much more superiorly located. Like in atrial fibrillation, I said multiple foci in both the atria. It was multiple foci all over. Then with respect to atrial flutter, I was describing single focus going on and on. It could be doing clockwise activity, it could be doing anti-clockwise activity. That was cavo tricuspid isthmus. What I'm saying at the moment is there's an abnormal focus around the AV node. This is like current rotating around the AV node. So most of the time, either he will say re-entry circuit or he will use the word circus movement. PSVT, paroxysmal supraventricular. The name paroxysmal tells you that the arrhythmia can occur at any point of time. This arrhythmia is usually seen in young patients. Like normally we read arrhythmias always seen in structurally abnormal hearts, but PSVT, the one important thing that I'm trying to tell you is that this is seen in a structurally normal heart. Most of the questions will begin by describing a young man or a woman, and there will be complaints of recurrent episodes of palpitations. Most of these patients will even say that whenever I drink tea or coffee, my symptoms tend to get accentuated because tea and coffee will be causing caffeine to go into the body. So therefore the rhythm, the abnormal circuit, the re-entry circuit current will rotate even faster. So the symptoms of these patients will be accentuated by tea and coffee. So most people will stop drinking it. A lot of these patients might be misdiagnosed as having anxiety neurosis or panic spells. So this is an important point, guys, that patients of PSVT initially may not come to you, and they might be going to a psychiatrist. And because nowadays mental health issues have anyway become so common that they might be started on treatment for panic attacks. They might be misdiagnosed as having generalized anxiety disorder, and most of these patients will say also, I'm okay, and then suddenly I get that feeling when my heart is beating very fast and I start getting dizziness, and there would be syncopal episodes occurring in these patients also. So what we need to do is specialized testing in these patients that I'll be explaining to you, so that we can identify the presence of this arrhythmia. Sometimes the heart rate of this patient will be totally normal. It's going to be silent. There's going to be like a total silence before the storm. And when the storm will come, then the heart rate will suddenly jump up to like 150, 180, 200, or even higher than that. That substantial increase in heart rate will contribute to a lot of discomfort in a patient. It can even contribute to development of chest pain. And that is when like you'll be able to identify. But one of the important things that you understand is that in PSVT, the abnormal current is rotating round and round the AV node of the patient. So we'll give a medicine that will be working on this AV node, and we'll also be doing vagal stimulation. Vagal stimulation is very effective in this because mainly the abnormal current is located around the AV node of the patient. So vagal stimulation like carotid sinus massage will work on this area. It will stop this re-entry circuit. Or we can go for phase ice pack. Phase ice pack will also cause vagal stimulation. The main point is in atrial fibrillation, the ectopic foci were multiple in the atria, above in the atria. In atrial flutter, it was one current rotating clockwise or anti-clockwise macro re-entrant circuit in the right atria of the patient, but now it is problem around the AV node. So that point has to be kept in mind. And why did I re-emphasize that is because in some questions, to make it sound sophisticated, he might actually speak about this abnormal current around the AV node as AV and RT. What I mean by the word AV and RT is AV nodal re-entrant tachycardia. So some questions of PSVT can be rephrased as saying AV and RT. That's just to make it sound a little more sophisticated. PSVT as a term is what we are more comfortable with. Now, before I focus on the specific ECG findings of this patient, what I mainly want to draw your attention to is that either in theory or in actual ECG that is given to you, you will always notice that these patients will be having a narrow QRS tachycardia. Whenever it is ventricular tachycardia, which is the next topic of after this, I'm giving you a heads up, he will always say wide or he will say broad QRS complex tachycardia. But every time you read this phrase in a question, narrow QRS tachycardia, especially says a young female or a male misdiagnosed as having panic attacks, or then he says also that this person had accentuation of symptoms on drinking tea and coffee. When they stop taking tea and coffee, the episodes have become less frequent, but still the dizziness and syncopal episode do occur in spite of giving tea and coffee. We think in terms of PSVT. We obviously need objective evidence. So what is the objective evidence is what I explained to you now. Now, coming to this case scenario, this was a 25-year-old lady, and she's come to the hospital because she says she fell in the stairs in the morning while she had a dizzy episode. Like, she's telling me that I was rushing to work and I did not have my breakfast, so I felt as if my head is spinning, and then I fell down the stairs. So she like twisted her ankle very badly. So primary reason why she has come is because she thinks that she's not able to do weight bearing. So she says like, I with a lot of difficulty I took auto rickshaw and I came to a hospital. Sir, I think I'm having some soft tissue injury, and can you just let me see an orthopedician and they can evaluate whether I need some kind of cast. Like, the person is trying to self-diagnose herself as suffering from some kind of a fracture and is insisting on me to write her an x-ray so that I can pick up any bony injury that she has sustained. I just casually asked her, okay, I'll write an x-ray for you because you're so insistent and I understand that you're not able to do weight bearing. But I said, are you on some kind of a medication? Because patient was looking very anxious and nervous. So she says, yeah, I have generalized anxiety disorder and my psychiatrist has put me on medications, but my symptoms are still persisting in spite of the medication. So I told her, ma'am, if you are having symptoms like palpitations and your blackout episodes, like did you become unconscious? She says, yeah. So I said, did you not tell your psychiatrist? She says, no, sir, I did not get time to, go and visit my psychiatrist. Most people try to save money or avoid visit to doctors. I mean, if she would have told that her, symptoms of so-called panic attacks and GAD are persisting in spite of anti-anxiety medicine, then they would have done an ECG. So I thought, okay, ma'am, I'll write you an X-ray also because you are having a soft tissue injury and you can't do weight bearing. I understand that you're having a lot of pain in your foot. We'll take good care of you, but you can get an ECG done also because you have these palpitations. So she was quick to, interject me and say, no, I don't need an ECG. In her mobile phone, she took out her phone and she said, like, last year, I was having these palpitations. So my mother took me to some doctor. They did ECG. It was normal. And prior to that year also, I was having problems. So somebody suggested an ECG, got my ECG done. So in her mobile phone, she is showing me two ECGs. And she's saying everything is normal. So I said, no, ma'am, I insist that since you're having these palpitations and blackout episodes, I don't think that you are having anxiety only. There must be some undiagnosed cardiac condition. Let's get an ECG done and then we will decide. So she reluctantly agreed for it, and I've got her X-ray of the foot because she was having just for a satisfaction fact, but I knew that it is a soft tissue injury. I got her X-ray done, and at the same time I got her ECG done as well. Now, in the ECG of this patient, the current one, you will notice that the heart rate of this patient is a little fast. I can say that it is actually 2.5 squares. It's not exactly 3 because, for calculation purposes, I'm saying 3. It's a little less than 3, I would say. So there is definitely a tachycardia present in this lady at the moment, and that could be because of the pain of the injury as well. If you fall down and you're having injury and it's hurting, there can be tachycardia, and I can see the T wave and the P wave in this patient separately. Because you can see the T wave and the P wave separately, my interpretation of the current ECG of this patient would be a presence of sinus tachycardia. Well, the logical explanation for a sinus tachycardia is that she had a soft tissue injury. It is hurting very well, so hurting too much. That is why sinus tachycardia. How do I know it is sinus? P wave is present. QRS is present. QRS complex is coming after the P wave, so it is a normal sinus rhythm. But the heart rate is little more than 100. I mean, 300 divided by anything less than 3 would be a tachycardia. So currently, when I saw her ECG and I told her it is normal, she said, no, doctor, I told you already my ECG is normal. I don't have a cardiac problem. I don't know why doctors are so insistent on getting ECG done. So I told her, ma'am, I knew your ECG will be normal. And she's giving me a quizzical look. She says, if you knew that my ECG will be normal, 2 times I got it done last year and last year. Now you made me, go to another line and get an ECG done, and I was in so much of pain and I got it done, and you knew it was normal, then why did you write it? I said, ma'am, I basically wanted to check out what is going on with your heart at the moment, but I suggest you that because you are having such attacks again and again, I suspect that even in the morning you could have a cardiac event. Because of that, you had dizziness and you fell down. So your injury is because of that cardiac event. And I suggest that we put a device on your chest so that we can record your ECG for the next 48 hours. Holter should be done in these patients who are having this so-called panic attacks. A lot of people self-diagnose themselves as having panic attacks. It's actually a Holter that needs to be done, and Holter can pick up recording for 48 hours. We can also do one more test in these patients that is called as a loop recorder. Both basically do the same thing, only with a Holter we can record the ECG over the next 48 hours, and we also tell these patients to note down the time whenever they have an episode like this. And loop recorder, the advantage is that it can do recording over the, because loop recorder will have a bigger hard drive, so it can store data for the next 7 days. So this lady finally agreed for when I said like this. She said, oh, nobody suggested me this earlier, so I'm okay for it. So now we are putting a Holter on our chest or a loop recorder. Like if the symptoms occur very frequently, then I'll put a Holter only. If the symptoms occur like once a week, twice a week, I'll put a loop recorder. But now this device will be put on the chest of this lady to record her symptoms and ask her to record her symptoms in a piece of paper over the next 48 hours to 7 days. Now when she comes back after 48 hours to 7 days, what we will do is download the data from the Holter of the loop recorder, and that is when we will try to check out, like the software will download the data, entire data of 7 days or 48 hours, and then the software will present before me what is going wrong in the heart of this lady. Let me just explain to you what is going wrong in the heart of this lady with drawing a normal ECG first, and then I'll explain to you what the superior ECG means. At the moment, everything is fine. Everything is fine right now. There's a P, there's a QRS, there is a T, and I have also made the heart rate of this patient normal. Like I put 4 large squares separating R and R waves. I'll just write that once again. I made like 4 large squares separating the R and the R waves of these patients. So everything is fine. Let's say the time is 5:30 in the evening. Everything is perfect. Nothing wrong with the heart of this patient right now. And she's telling me yesterday 5:30 in the evening, 5:31, I had an episode. So when I'm downloading the data, because the Holter will tell me, at that time, what would have happened is that because of the re-entry phenomenon starting, the T wave and the P wave, you can make out the T and the P by the difference in the vertical height will come closer, and even these R and R waves will come closer. What I'm saying is that due to that re-entry circuit, there will be a faster activation of the ventricles. So all the waves will start coming closer in the ECG of this patient. So what you will notice is the ECG recording will change. Suddenly the QRS complex will become narrow. Normally, like whenever I draw QRS complex, it is like luxurious QRS. Now it's like literally everything is jumping on each other. Everything is jumping on each other. And what you are seeing in the ECG, let me just draw a couple of complexes and I'll be able to explain this better to you, is a kind of a recording that is given superiorly in the blue, but instead of like marking on that blue recording itself, I thought I should hand draw this so that I can explain this findings to you better. Now, the first thing that I've said is that 5:30 in the evening, like on a loop recorder, everything was okay, and in 1 minute everything changed. Maybe she had a coffee, maybe she had a tea, maybe she did not do anything, but suddenly this re-entry circuit has started. Suddenly it starts by itself. So that's why the word is paroxysmal. And then you are noticing the first ECG finding that is coming up is narrow QRS complexes that will be appearing. Along with narrow QRS complexes, suddenly the heart rate has jumped up to 150 beats per minute. And that's really fast, guys. If you've ever been to a gym, if you're doing weight training and you are trying to do a lot of cardio, 150 really makes you feel uncomfortable. So because the heart rate has suddenly jumped up from 75 beats per minute, earlier it was 4 large squares, no? So the heart rate was 75 beats per minute. And you will notice that on the display, the heart rate has suddenly changed to 150 beats per minute. So I've written the word tachycardia, narrow QRS complex. Because of that sudden increase of the heart rate, there is also an increase in oxygen demand of the heart, and this increase in the oxygen demand of the heart is causing this development of a ST segment depression. Even in the superior ECG, you will notice that a bit magnitude of ST depression is present. This will be a global ST segment depression, that it will be present in all the leads in the ECG. The reason for this is increase in the demand. See, I'm not saying supply of the heart is less. I'm saying there is an increase in the demand. The supply is normal, so there is a mismatch between the demand and supply. The coronary arteries of this patient, young lady, is perfectly normal. Supply is normal in the heart, but there is an increase in the demand. There is a mismatch between the demand and supply. My statement is, why is there a ST depression? The reason for ST depression is a mismatch between the demand and supply of this patient's heart. That is why there is a ST depression that would be coming up. And then when you check out, you are noticing that this single wave is coming. When I'm putting the star mark, and even in the superior ECG, you can see that now you cannot see T and P waves separately. Now the T and the P waves are merging with each other. This T and P, this T and P, they are coming closer to each other and are merging with each other. So the next finding that I'm saying is hidden P waves. Mark my words there. I did not say the word absent P waves. Absent P waves are seen in atrial fibrillation at the moment, or in the sick sinus syndrome. But at the moment, I'm saying the word hidden P waves because they buried in the T wave. That is why there is a single wave that is coming in the ECG of this patient. These are three diagnostic criteria that you need to remember for the topic of interest: paroxysmal supraventricular tachycardia or AV nodal reentrant tachycardia. Had I said these findings on the first slide itself, it would not have made too much of sense. But now what I'm trying to explain to you is the same ECG. You can check out there is a single wave present between the R and the R complexes. That is due to merging of the electrical activity of the R wave, merging of electrical activity of the T wave and the P wave, and there is like a buried P wave present in this patient. The main feature is paroxysmal, that this arrhythmia can start by itself, it can stop by itself. Lots of time these patients may say that when I'm feeling dizzy, I splash cold water on my face and I feel better. I'm like, what? She says, yeah, sir, I used to have these episodes now. So I used to put splash cold water on my face. I used to feel better. Now I'm correlating. Oh, she's splashing cold water causing vagal stimulation. That can cause a self-termination of this arrhythmia. Guys, this is the only arrhythmia that can start. All arrhythmias will start by themselves, but this shows a spontaneous termination. You don't read about spontaneous termination with any other tachyarrhythmia except for the one that I'm talking about. PSVT can show a spontaneous termination by drinking cold water, splashing cold water on the face, because vagal stimulation will work in these patients. So this is what is seen in young people. It is seen in structural normal heart. A lot of these patients can be misdiagnosed as having anxiety neurosis. That is why a Holter or a loop recorder should be done in these patients. Holter can record data for 48 hours, loop recorder for 7 days. And the highlight of ECG would be a narrow QRS tachycardia, a global ST segment depression, and then a hidden P waves. Every time I put a star mark anywhere, it's like a hidden T wave. Contrast this with what we saw when she came. Then we could see the T and the P separately. So I'll do the marking. This is P wave, this is RS, and this is T. So I've done normal sinus rhythm. We can see a P followed by a RS, then is followed by a T. Again there is a P, T, and then a P. So you can see that you can see two waves now. You can see two waves, the T and the P separately, and the heart rate of the patient is fast. So if they give you a ECG like this, in which you can notice that heart rate is fast and at the same time T and P can be seen separately, and you can differentiate them on the basis of the height. You can see P wave is much more shorter, 2.5 millimeter. T wave is 5 millimeter in height. I've already told you that, guys. So therefore you can discriminate between the two. And the highlight is the first ECG that I've shown before you. When she came to me, she did not have any cardiac complaints. She was having that injury in her foot, and that was making her uncomfortable, so only sinus tachycardia. But subsequently in this patient, we have been able to demonstrate a proper run of PSVT, because of which she could have even had a syncopal episode subsequently, or a dizzy episode. And now she's saying, okay doctor, I understand that I have a problem, what should be done? So let's look at what should be done in these patients. The question will say prevention of episodes of PSVT. If it is recurrent episodes happening, guys, if it is recurrent episodes happening, what you should be doing in these patients is that you will tell her that there is an abnormal circuit around your AV node and we can destroy it. So catheter ablation is recommended. But if it is sporadic episodes, then it is pill in the pocket approach. What I mean by pill in the pocket approach is that if the symptoms of the patient are not going to be on a recurrent basis, we can use a calcium channel blocker like verapamil. Verapamil, how does it act? It acts on the AV node and it causes a prolongation of AV nodal delay. Verapamil, how does it work is it causes a prolongation of AV nodal delay, that is the MOA of it, and can be used. So in patients of PSVT, recurrent episodes, catheter ablation, if it's like once in 1 month, once in 2 months, then pill in the pocket, you have an episode, take verapamil, and that would help you feel better. If he mentions that the patient has come with suppose this question said undiagnosed case of PSVT has now been brought in the casualty with unrecordable BP, then for unrecordable BP, we will straight have to give a DC shock. I've already explained to you that arrhythmias, if they cause a hemodynamic compromise, the definition of the word hemodynamic compromise would be that systolic blood pressure is less than 90 and diastolic blood pressure would be less than 60 millimeter of mercury. However, the question, if it mentions blood pressure to be more than 90, if it does not say the word crashing patient, he says she has been brought to the hospital and she is having a run of PSVT right now. She's having PSVT right now. What will you do? But the BP is more than 90 by 60. Then your first answer is I will be doing a carotid sinus massage, that is vagus stimulation should be the first approach. Before I write anything further, I just want to bring to your attention MCQs of PSVT can be going in any of these three directions. If he himself will say unrecordable blood pressure, patient is unconscious, then synchronized DC shock, no role of medicines. If he says, how do you prevent an episode from occurring, catheter ablation and verapamil. If patient is having an acute episode right now, she's having palpitations, heart rate is 200, and the BP of the patient is like more than 90/60, then it is vagal stimulation. We will either go for carotid sinus massage, or instead of carotid sinus massage, what we can also do in these patients is a face ice pack. I'll ask my nurse to put some ice in gloves, and then we can put it on the face of the patient. That will cause a vagal stimulation. Meanwhile, my nurse on my orders will also get me an injection. Like I put a IV line in this patient, and my nurse would now be giving me adenosine, that is 6 milligram. We give a first dose of 6 milligram. We give a next dose. They don't ask you. This is just to tell you that we might be using up to 18 milligrams in 2 dosages and every time we give adenosine, it has to reach the heart. So we should also be giving a push of normal saline. This again, it's a practical information that you should be knowing, that after giving adenosine, you should write in orders only, so that your nursing staff can follow that 20 ml normal saline push should be given, so that the medicine can, because if you're giving chota sa dose here, the medicine will remain in the arm only, no? So give a 20 ml push after giving adenosine so that the medicine reaches up to the heart. So there are 3 possibilities that you need to remember. And if after adenosine still if it is not responding, you anyway have access to synchronized DC shock. You see, if chemical cardioversion is failing, if adenosine is not working, you can still go for synchronized DC shock. So in PSVT MCQs, there can be 3 possibilities: crashing patient, acute attack, crashing patient, acute attack, stable patient, versus prevention of episodes. This I would rate as an important slide, because most questions of PSVT, people don't make a mistake with respect to identifying it in the ECG. Mistake is with respect to that they answer adenosine for every scenario. Adenosine is only to be answered if he is hemodynamically stable. He or she is hemodynamically stable. Don't answer adenosine blindly for all questions. A lot of MCQs will be having answer as vagal stimulation, first line management. He is asking first line management. It's not adenosine. It will take some time for you to give adenosine, right? So it is vagal stimulation. A lot of questions having crushing, synchronized DC. For prevention episode, it is catheter ablation. So I agree that the drug of choice for chemical cardioversion in PSVT is adenosine, but then is usually like a subsequent data. For vagal stimulation, what we can do is carotid sinus massage, understandable, but carotid sinus massage is contraindicated in older patients who are having atherosclerosis of the carotid artery. In old patients, if you're having atherosclerosis of carotid, you give carotid sinus massage, it will cause atherosclerotic fragments to break from here and go in the brain, and it will cause stroke. First, do no harm to the patient. No, I mean, I can't give a new disease to my patient. So atherosclerotic narrowing of the internal carotid artery is a big problem that can be occurring. And then is like a modified Valsalva maneuver. What I mean, face ice pack, I've already told you. Modified Valsalva maneuver would mean that you will take a syringe. You can take a 20 ml syringe. You can take it out, and then you can give the side of the syringe which has that small nozzle on one side on which you attach the needle. So you can give a 20 ml syringe to the patient, and you can ask him to put it in his mouth, the tip of it, and then blow into it as hard as you can. You will ask the patient to, put that syringe, the nozzle part which is attached to a needle, between his lips, form a tight seal, and then blow hard. I mean, use your diaphragm and blow hard as you can. And when he's trying to blow that hard for like 15 seconds, after that, we raise the leg. That will improve the venous return to the heart, send more blood to the heart, and then subsequently the patient can be made to sit up. This is what we call as a modified Valsalva maneuver. For modified Valsalva maneuver, use the biggest size syringe that is available. Most of the time in the casualty, it is 20 ml syringe that we use for sampling can be available. You can use a bigger syringe if possible, but then modified Valsalva would mean like, asking the patient to pinch his nose and breathe out is not very effective activity. It is like pushing out on a syringe is what is recommended. So carotid sinus massage, modified Valsalva, and face ice pack are like 3 methodologies by which we can activate the vagus nerve. And apart from this, like I've told you, most questions would go in the following direction. Now we'll talk about ventricular tachycardia. Ventricular tachycardia is very easy to identify because most questions will either give the ECG or this theory, and he will say the word broad QRS complex tachycardia. I'll give you the reason for this broad QRS tachycardia also, but at the moment, whenever it is gonna be like a paroxysmal supraventricular tachycardia or SVT, it's narrow QRS. If it's gonna be like VT, it's a broad QRS. You can see this does not even look like a normal ECG. It's only broad RS complexes are. All you see is RS complexes. Everything that goes up is R, anything that comes down is S. So it's like RS complexes occurring on a recurrent basis. Now let us understand why that is happening. In this patient, there is an ectopic focus in the ventricles. There is an ectopic focus in the ventricles, and this abnormal focus in the ventricles is trying to control the ventricles. In this patient's heart, the SC node will be able to control the atrium. Patients of VT, the atrial rate will be decided by the SC node, not a problem, 100 per minute. That's the max rate. But in the ventricles, there is an ectopic focus which has been created. The reason for this single ectopic focus can be myocardial infarction, or it could be hypertrophic cardiomyopathy, or it could be drugs also. But the message is the ectopic focus will usually in this patient fire at a rate of 200 per minute, and it will be determining the ventricular rate. So once again, before you, I've introduced a condition where atrial rate and ventricular rate is not matching. Just a couple of, I would say, if you go back in the video, I taught you a condition by the name of complete heart block, where atrial rate was 100 and ventricular rate was 40. Now I'm teaching a condition where atrial rate is 100 and ventricular rate is 200. So one, I'll introduce a term by the name of AV dissociation. And the moment AV dissociation comes in, lack of coordination between the two chambers of the heart is coming. And if there's a lack of coordination, then BP will begin to form. You see, there are two problems in this patient. One, the heart is beating just too fast. Pathological tachycardia is what I'm saying. Whenever the heart will beat very, very fast, it will get less time to relax. That will cause crashing of BP. And second, there is a AV dissociation. There is lack of cooperation. There is lack of coordination between the two chambers of the heart. So again, the BP is falling. You can see there are two factors which will operate in VT to make the patient pulseless. Most MCQs will say the word, or you would have read in the books also the word PVT written. PVT is written as pulseless ventricular tachycardia. Guys, I've tried to explain to you why are we calling it pulseless. We're calling it pulseless because one, the upper chamber and lower chamber of the heart are not working in sync. They're working independent of each other, which is responsible for like impaired ventricular filling. And atria contribute 30% of filling of the blood ventricles. If atria and ventricles don't cooperate, 30% filling is gone. That was 30% decrease in systolic. And the remaining falling is because of the pathological tachycardia component. And well, a lot of people are able to identify this because AV dissociation will cause pulsations in the neck of these patients, that is called as Canon A waves. So like Canon A waves are what you read 2 times in your career. One is with respect to ventricular tachycardia and second is with respect to complete heart block. The common thing between the two is AV dissociation, and lack of coordination will cause these big pulsations in the neck. In fact, these Canon A waves are also called as frog sign. In fact, after you are done with this video, if you get an opportunity on YouTube, just type the word frog sign and with my name, and you'll find a video in which I've shown a patient having very prominent pulsations in the neck. That is Canon A waves are seen in VT and in patients of complete heart block. And even if you don't remember this information, well, how do you crack this question is on the basis of broad QRS complex tachycardia. Most of the time, this complication can be seen right after MI. Usually like first hour of myocardial infarction is called as the golden period. So that is when this kind of an unfortunate complication can be occurring. And therefore, let's just put up the diagnostic criteria. He will say broad QRS, more than heart rate, more than 100 beats per minute. In fact, why do you get a broad QRS complexes in this patient is because the current in this patient will now be spreading myocyte to myocyte. Like in this patient, the current will not utilize the Purkinje fiber. You can see I've shown in dotted that even in the heart of these patients, there is presence of intermyocyte conduction. This you don't need to note down. I have told you the concept of intermyocyte conduction even in WPW syndrome. In WPW, I was telling you that the impulses are going in the ventricles and then they are not following Purkinje. Same here, Purkinje is not getting utilized. Intermyocyte conduction is always slower. Intermyocyte conduction is always slower than the firing of the Purkinje. So if you do not utilize the Purkinje, and I'm saying the word slower, please just focus on the English word slower and tell me what will happen to RS complex. Will it be normal duration? Will it be narrow? Will it be broad? It's gonna be broad. It's gonna be slow now, so it's gonna be broad. Guys, broad RS complex क्यों होता है is what I'm trying to teach यार, that इसका ventricle जल्दी contract कर रहा है. It's not getting filled with blood properly, so blood pressure is bound to fall. There's a pulseless VT, and I've also tried to give rationale why it is a broad RS complex. The broad RS complex is primarily because of the slow intermyocyte conduction. When I say like this, the query of a lot of students is, sir, then why is the heart rate increase if there's a broad RS complex? By heart rate is not decided by the QRS complex duration. हार्ट रेट कैसे डिसाइड करते हैं? फर्स्ट थिंग में सिखाया था ना, हार्ट रेट इज डिसाइडेड बाय आरआर इंटरवल. रिमेंबर ईसीजी का जो रूल है, हार्ट रेट कैसे डिसाइड करते हैं? इट इज बेस्ड ऑन आरआर इंटरवल, वेयर एज दिस पेशेंट्स आरआर इंटरवल इज रिड्यूस ना, सो टैकीकार्डिया. तो टैकीकार्डिया वर्ड कहां से आया? टैकीकार्डिया वर्ड इज कमिंग फ्रॉम आरआर इंटरवल. देयर इज हार्डली वन लार्ज स्क्वायर सेपरेटिंग आर एंड आर, सो द हार्ट रेट इज गोइंग अप टू as much as like 200, even going up to 300 per minute in this patient. If it's 1.5, it will be 200. If it's 1, it is 300. So tachycardia कहाँ से आया? RR interval से. Broad QRS कहाँ से आया? That intermyocyte conduction. Only explanation part, guys. That's important. Medicine is all about why. अगर आपको why पता चल जाता है, you are bang on spot for understanding and remembering the data. And now, like most of MCQs will say, I mean, first line is more than sufficient. Otherwise, like traditional books will say PVC, premature ventricular contraction. Why you say premature is because ventricles are contracting earlier than normal thanks to this ectopic focus. He's making everything doing faster. When you do fast work, then chalu kaam hota na, chalu kaam hota jaldi kaam karna. That's why there would be premature ventricular contraction. Then there would be Josephson sign. For Josephson sign, I'll just highlight this. When you scan the ECG of this patient, in the downswing, you'll usually see a notch happening. Like, when you check out the ECG, you'll notice this slight notching that is happening like this way. This one is more prominent. I'll just zoom it in. Yes, it's more prominent now. And let me use a finer pen to highlight this. You can see the R is going up like this, and then you can see the downswing of the S. There is like a shelf or a notch that is present, that is called as Josephson sign. Not that it is a very important diagnostic feature, but when I spoke to my students after the paper, they said, no, sir, it was a very prominent one that was present. So I thought I should just mention regarding Josephson sign, where I put this arrow like this. Josephson sign is where I put this horizontal arrow like this. Then they can be having capture beats. Capture beat would mean intermittently in between the two. The ECG of this patient can become normal also. Like in this particular ECG, everything is normal. But I'm saying that in between, you might notice that you might get a normal QRS complex in this patient, and then the arrhythmia will once again start, and then again the same thing would be occurring in this patient. So intermittently, like you might be having, the word is might be having, is a presence of a normal sinus rhythm. So SC node is trying to reestablish its superiority once again. So you can get a capture beat, or you can get a fusion beat, or they can be mention of extreme axis deviation. These are only for theory MCQs, guys. That is capture beat, fusion beat, and extreme axis deviation are only gonna be theory components. The main funda for practical in the exam or in your ward living or in MCQs or in actual clinical practice would be broad QRS tachycardia with a Josephson sign. The heart rate should be more than 100, and why we call it premature is because only ventricles are firing again and again at a fast rate, and premature is bad. I explained that earlier, say that again. Why bad? Because the heart is not getting time to fill with blood, and that is why that the output from the heart of these patients will begin to fall. Pulseless ventricular tachycardia, if he says, what will you do? Your answer will straight away be given as defibrillation. Yes, guys, we need to defibrillate these patients. It's non-synchronized DC shock. For stable ventricular tachycardia, the drug of choice should be answered as amiodarone. That has already been discussed. Amiodarone is used in atrial fibrillation, atrial flutter, and now for stable ventricular tachycardia. But if he says pulseless, then it is defibrillation only. If he says what is the drug of choice for post-MI ventricular tachycardia, then it is amiodarone. But if he again mentions unrecordable VP, straight away go for defibrillation. Cardioversion is what is called as synchronized variety of DC shock, and defibrillation is what is called as non-synchronized variety of DC shock. So one, you need to get the terminology right. You see, in any arrhythmia, if there is going to be presence of R wave in the ECG, then the computer will search the R wave and deliver the DC shock. Like if I draw this ECG once again, where there was a narrow QRS complex with ST depression, a single wave like a PSVT with a hemodynamic instability, R waves are present. So computer will be able to pick them up, and then he will be able to deliver. The R wave is pointed, no? R wave is pointed, so it will be able to deliver the impulse. But suppose a person is having ventricular fibrillation, like let me draw this ECG before you. Ventricular fibrillation is like this twitching happening. So there is no R wave. The computer will get confused now. If the computer will get confused, you have to resolve it by just switching the toggle switch. Like there's a sync mode, there is a non-sync mode for ventricular fibrillation and PVT, guys. These are the only two arrhythmias where like you don't have proper R waves being formed. So what you need to do is, because in VT also, no, when you look at the ECG, it's like much more broader like this. No, it's not like a normal well-defined R wave that is present. So the computer is not able to see. You and me can pick up anything that goes up is R, anything that comes out in the ECG, a big wave is gonna be R and S respectively. But you can't teach a computer that thing. Computer can pick up only that where a pointed wall of R wave present. So what I just want to bring to your attention at the moment is two arrhythmias where we go for defib or non-synchronized DC shock is VT and ventricular fibrillation. For all others, it is always a synchronized mode or DC shock that we'll be using. And the only variety where we use a low intensity DC shock was for the case of atrial flutter. Okay, so next we'll discuss a case scenario that was asked in FMG exam. He said 20-year-old guy with depression with suicidal tendency has been scheduled a ECT, electroconvulsive therapy for next Monday. On the weekend, like he consumed 20 tablets of amitriptyline, that is TCA, and he's found unconscious by the mother. Is rushed to the ER. The pulse rate is 200 per minute. That's corroborating with the ECG. I mean, the heart rate is like almost 1.5 large squares separating the R and R. And considering that 1.5 large squares, 300 divided by 1.5 will work out to a heart rate of 200. BP is like 100 by 60. That's pretty decent. I mean, I'll not go for defibrillation for this case. Cardioversion is anyway out, as I've told you on the previous slide. So the answer is not defibrillation. We are now left between soda bicarbonate and amiodarone. Now it looks like amiodarone should be the answer in this patient considering that the BP is 100 by 60. But I would just like to bring to your attention of aspect from pharmacology. Like this, I would say is an integrated question from both pharma and medicine, that tricyclic antidepressant toxicity. I mean, this causes metabolic acidosis. So even if I will give amiodarone to the patient, it will suppress this arrhythmia till as long as amiodarone effect will be there. But once the effect of amiodarone will go away, the arrhythmia will show a tendency for recurrence. So what we need to do in these patients is treat the metabolic acidosis component using soda bicarbonate. You see, earlier this used to come as a one-liner. What is the antidote for TCA toxicity? That is soda bicarbonate. Now he made it clinical, that he put a proper ECG in which there was presence of a heart rate that is 200 per minute. Along with this, you can pick up the R wave and the S wave, and the gap between the two is very substantial. It's almost like one large square. So I can say that the RS of this patient is 200 milliseconds. Remember, I told you normal QRS complex is about 80 to 100 milliseconds. Normal QRS complex, I explained right in the beginning, is about 80 to 100 milliseconds. And here, like the RS complex of the patient is turning out to be 200. That is from where the word is coming as broad RS. And the tachycardia component, so it's a broad RS complex tachycardia, which is triggered by metabolic acidosis. The protons are causing damage to the heart. They're causing a ectopic focus being created. It's firing very fast. And that is why like this patient is having these, the patient's pulse rate is turning out to be 200. The main concept what I want to say here is, like, if he said a crushing patient, understandable defibrillation, but what he wanted to see was that, are you aware that we need to treat the cause of the disease? I mean, we need to, I understand that we need to fix the ventricular tachycardia component, but if I give amiodarone, I will be able to suppress the arrhythmia for a short duration. It will tend to reoccur once the effect of amiodarone will go. So you treat the metabolic acidosis component using soda bicarbonate. So ABG also needs to be done so that we can calculate exact bicarbonate, and based on the bicarbonate value, then I will be giving bicarbonate correction for management of this patient. How to give bicarbonate correction, I've talked in the electrolyte section. Now we reach to a very interesting ECG, which looks almost identical to the previous ones that I've shown. But you'll notice a subtle difference, and the subtle difference would be as follows: that when you look at the size or amplitude of each of them, right? I mean, the amplitude of all of them is not identical. The amplitude of each one of them is fluctuating all through. Some of these complexes are relatively bigger, some of them are like progressively smaller, as you can see. So I can say is that overall, if you look at the size of these broad QRS complexes, because it is not equal, that is why the word is polymorphic ventricular tachycardia. In fact, to the previous discussion that I showed you currently, you will notice that almost all the QRS complexes are of the same size. So what I can say for this particular ECG is also the word monomorphic, like this person is having a monomorphic ventricular tachycardia. Even in the previous one that I showed before you, you can notice that all of these are almost having same size. So this would be again called as a monomorphic ventricular tachycardia. I mean, the amplitude of the QRS RS complexes is what I'm talking about. It is an equal size, that is the word monomorphic. But for the current one that you have currently seen on the slide, because the size is variable. The word is polymorphic VT. So the point to be understood and remembered is very simple, that when I say the word polymorphic ventricular tachycardia, it is a cousin brother of ventricular tachycardia. Even in this case, the RR interval will be reduced. Even in this particular case, there would be broad RS complexes. Ventricles will be contracting faster, so BP is bound to fall. If the BP is unrecordable, I'll give a DC shock. Otherwise, like I can manage the patient with magnesium sulfate. I'll write down the drug of choice in a while. But because you are able to answer all this, so question will usually say the cause. And the cause to be remembered is mainly electrolyte imbalances, which are enumerated, but still for practice sake, this is the most important part of this particular slide. They will ask you electrolyte imbalances can trigger which arrhythmia. Hypokalemia, hypomagnesemia, hypocalcemia are three important, I would say, electrolyte or dyselectrolytemias which trigger this arrhythmia. Then is class 1A and class 3 drugs. Class 1A would be like quinidine, procainamide. Class 3 would be drugs like sotalol. They can trigger this arrhythmia. When I say like this, the query of a lot of people is, sir, you are saying antiarrhythmic drug is causing an arrhythmia. Antiarrhythmic drug is supposed to treat an arrhythmia. I agree to that. But here I'm teaching you antiarrhythmic drug is the cause, because antiarrhythmic drugs can be a villain in your hand. They can be an angel. If you use too much of something, it can cause an arrhythmia, that is polymorphic VT. Then you will notice that cardiologists like dislike writing macrolides always. In fact, erythromycin, fluoroquinolones, they are like they have potential to contribute to prolongation of QT interval and then cause polymorphic ventricular tachycardia. So even TCA, though I discussed TCA for development of VT, it can contribute to even a polymorphic VT. SSRI is overdosage of the same. Then is haloperidol. So these drugs can be asked to you, including one more that I'm writing. This drug is a banned drug, but this is an antihistaminic drug. It is present in some cough syrups, and this was again a neat PG question, that estemizole results in development of which arrhythmia. Then it is polymorphic ventricular tachycardia. Other causes can be like starvation and hypothermia. Well, for hypothermia, I would like to say that one ECG finding that I'll introduce subsequently is called as J-wave. But at the moment, the point is that starvation, hypothermia, when patients are critically sick, can trigger this arrhythmia. Then there can be congenital causes also, which have fancy names like long QT syndrome, which is a potassium channel defect. Then Jervell-Lange-Nielsen or Romano-Ward. Jervell-Lange-Nielsen has a associated deafness also present. But mainly what I want you to focus upon for this particular slide are the causes, which are electrolyte imbalances, then are drugs, each one of them, guys. Like earlier I just said TCA and I moved on, right? But for polymorphic VT, it is class 1 and class 3 that they works. Then which antibiotics? So two of them, like macrolides and fluoroquinolones. TCA, SSRI, haloperidol. Haloperidol comes in so many, it also causes drug-induced Parkinsonism. So there's no limit to the amount of data that you can remember. But yeah, the important ones are what I'm trying to focus at the moment for polymorphic VT. Now you will also notice that sometimes they might be using a Latin terminology describing this, which is called as Torsades de Puentes. So the diagnostic criteria for this would be that there should be a run of polymorphic VT as I shown on the previous slide, but there should be a preceding QT prolongation that should be documented. And then he also says this word twisting of points. What I mean by twisting of points is like, you would see some people working out in a gym. So if you are using those two ropes, you can notice that the amplitude of these may not remain the same. The amplitude will keep on variable. So like Torsades de Puentes and polymorphic ventricular tachycardia are not like to be used interchangeably. For saying the word polymorphic ventricular tachycardia, we need to demonstrate the presence of QT interval prolongation, and most of the time they might even make it more fancy by writing the word QTC. QTC, the chota c basically says the word corrected, and it is QT divided by the root of RR interval. This is a mathematical formula that has been asked in basic sciences. I think it was in physiology that they asked it. The chota c basically means corrected. It is QT divided by RR interval. For the drug of choice for polymorphic ventricular tachycardia, there's never a problem. That is magnesium sulfate. So as such, I can say identifying the arrhythmia is not a problem. Magnesium sulfate, the same drug that we use for management of eclampsia, is the one that is being used here. It is just that I want to bring to your attention that it is not the identification, because you can easily identify the variable amplitude of the complexes. What you need to identify for the question is the causes which could be responsible for development of this tachyarrhythmia. And now we'll talk about like a couple of summary of tachyarrhythmias. The important summary which I would like to draw before you is like I drew it. Let me just draw this atrial fibrillation. Take out a pencil and try to do this activity with me. Try to show some twitching activity and show a variable RR interval, like show that the RR interval is not constant. It is showing an extreme amount of fluctuation. So the current sketch that I made before you is for atrial fibrillation. In contrast, the next one that I'll make before you, I'll first try to make it almost identical to what I have drawn previously or superiorly. But this time what I'll do is that I will be showing in these patients some P waves also. I'll try to show some T. And these P waves that I'll show you, these would be having variable size. So what I want to bring to your attention is that I am showing at the moment is presence of multifocal atrial tachycardia. I'm showing is multifocal atrial tachycardia. And you can notice that I have introduced P waves, right? I mean, if you look at this representation, the P waves have been shown to be having a difference in their physical morphology. So the second ECG looks like the first one in a sense that irregular RR interval is present, but then there's a fundamental difference between the two with respect to the P wave morphology. Now I'm going to draw an ECG in which there would be presence of sawtooth waves. That is easy to spot, that sawtooth appearance. It could be 2, it could be 3, it could be more than these also. So sawtooth waves as such, I don't think so would ever cause an issue. And after the sawtooth waves, the next one that I'll draw would be PSVT, where I'll show only a single wave, You can see a single wave has been shown at the moment. So this is like totally different from the superior ones. Young person will be given, usually tea coffee trigger can be given, improvement with cold water can be present, that is PSVT, paroxysmal supraventricular tachycardia. Then is coming up that physical appearance of ventricular tachycardia, the broad RS complexes. I mean, if you hand draw this once, guys, you'll feel much more comfortable with this. And sometimes like it may not be having a Josephson sign, it just looks like a spindle. And the next one that I'm showing, it is having a variable size. Like you can see that I've deliberately made some broad QRS complexes much more taller as compared to others. That would be a polymorphic VT. And lastly, I can say that if it's a twitching activity like this, it is ventricular fibrillation. So this that I've currently done, I have deliberately spoken fast here. I've deliberately like drawn this relatively fast to basically sensitize and train your brain to identify these tachyarrhythmias. It's a very quick job, guys, that you need to do in the multiple choice questions, which is atrial fibrillation. The second one that is shown is also having an irregular RR interval but is having variable morphology of the P wave, so is MAT. Then is atrial flutter, for which we use a low intensity DC shock. The subsequent one is PSVT. Then is monomorphic ventricular tachycardia. I've not written the word monomorphic because I've already emphasized on this. But for the next one, I have to write because the size of all of them is variable. So polymorphic VT. And the last one is obviously ventricular fibrillation. So this would be like a summary of those fast rhythms that I've currently explained to you. And now we'll be in a better position to understand these points like narrow QRS tachycardia. The ECG findings, as I've drawn before you, would be seen in like PSVT, paroxysmal supra. You may write the word SVT, or you may write the word PSVT, or you might write the word AV-NRT, that is AV nodal reentrant tachycardia. Broad RS complexes, QRS complexes, and presence of tachycardia has been discussed 2 times. One with respect to VT and second with respect to polymorphic ventricular tachycardia. The ECG I'll just quickly sketch once again. I mean, with Josephson sign highlighted, or sometimes that Josephson sign may not be visible as well. But in the superior one, the PSVT part, there was a very significant ST segment depression, that is that down sloping ST segment depression. And along with that, there was a single wave that was formed by the merging of the electrical activity of the T and the P. Then is delta wave. Delta wave is discussed for WPW syndrome, in which the moment the P will finish, there would be a starting of a R, but then there is a change in the slope in the upswing of the R, which has already been discussed. Now coming to the J wave and the Osborne wave, what I want you to remember is that this would be a soldier buried under ice at Siachen Glacier. And you will be noticing is the following change in the ECG of this patient, that is in the downswing of the RA. You are noticing a slight aberration that is coming. This is what I've shown is called as a J wave or Osborne wave. So I want you to pick up the delta wave is in the upswing of the R wave, whereas when it comes to the J wave or Osborne wave, which is encountered in hypothermia, the statement I've already told you in the previous slide, hypothermia, but this time I wanted to bring to your attention that it is in the downswing of the R wave. Contrast this with epsilon wave, which is seen in arrhythmogenic right ventricular dysplasia, and you will be noticing aberration that would be present, or like a M-shaped pattern that would be visible at the isoelectric point. This that I've currently shown before you is epsilon wave. It is seen in ARVD, that is called as arrhythmogenic right ventricular dysplasia. So these are like a summary of couple of abnormalities of the QRS complex that I have currently shown before you. Now we'll focus on a mnemonic for abnormalities of the ST segment. Electrolyte imbalance that has to be remembered is hyperkalemia. Then is left bundle branch block. Then is E, this is physiological waves. This is physiological. This can happen in a normal person like you and me also. We call it early repolarization variant. There is nothing pathological about it, but I still had to complete it in the mnemonic. VS stands for a complication of myocardial infarction. You see, MI can cause structural damage to the heart. This structural damage can result in arrhythmia. The name of this arrhythmia is ventricular aneurysm. Then alphabet T is for trauma. This trauma could be like while doing pericardiocentesis, like when we are doing pericardiocentesis, the needle can damage the myocardium. You see, we have to put a pigtail catheter, but initially when we introduce the needle and if we are not doing it guided, it has to be done guided, but let me say if it's not done guided, then it can result in ST segment changes. Then is ischemia. It is ischemic injury. Ischemia would mean obviously myocardial infarction, which is anyway a separate video. I'll just draw the ST segment elevation in myocardial infarction, which will always be having a convexity with a T wave inversion. Alphabet O would stand for Osborn wave, because Osborn wave is included in the discussion because it is occurring at almost the same level of the ST segment. Osborn wave is a feature that is seen in patients of hypothermia. Then alphabet N is the important one not to be forgotten. It is Prinzmetal angina. Now, I was not able to fit Prinzmetal angina anywhere, so I had to do this terminology that is called as non-occlusive vasospasm. When I say the word non-occlusive vasospasm, that would be called as Prinzmetal angina. You call it variant angina, and this is the only angina having a ST segment elevation. All anginas would be having is a ST segment depression. Then alphabet A is for acute pericarditis. And alphabet B is for Brugada syndrome, which is a channelopathy. It's actually a sodium channel defect, which is to be remembered. Acute pericarditis will always be causing is a ST segment changes, but it would not be convex, it would be concave in upward direction. Acute pericarditis, you always get a ST segment change which is concave in upward direction, and then Brugada has a co-pattern of ST segment elevation. At this moment, I would like you to just focus on the theory component, because Brugada as a disease I've discussed separately in the video as well, but at the moment, like, this co-pattern is again a ST segment elevation. So there are three ST elevations that I've talked about. One of them is ST elevation that is going to be convex in upward direction. Another one is ST elevation which is concave in upward direction for MI and acute pericarditis, 2 on the agenda. And for the co-pattern, I would like to reserve it for like a separate discussion that is already present in the app. You can see that with the broken heart syndrome, that is Takotsubo cardiomyopathy. So this mnemonic helps you remember the causes of ST elevation, which will be compared with ST depression. ST depression is the mnemonic is CHIPS. It's much more simpler and easier. Chronic stable angina, where we are doing stress testing, where we make the patient walk on a treadmill. Then hypokalemia, that's easy. Hyperkalemia, ST elevation. Hypo, the arrow is going down, no? So ST segment depression. Then is an important one, posterior wall MI, subendocardial ischemia. Subendocardial ischemia can be due to hypertension. Subendocardial ischemia can be due to left ventricular strain. Anytime when the left ventricle is having to do more work, that is hypertrophic cardiomyopathy, for example, valvular aortic stenosis, you have increase in the demand that causes subendocardial ischemia. And then is digoxin, that again is an important entry. So in ST segment depression like hypokalemia, chronic stable angina, koi galti nahi karta, they chip se yaad ho jata hai. What we need to remember is mainly that posterior wall MI part, where we have a ST segment depression, because the damage is piche na, so ST segment depression and then digoxin. In fact, when it comes to question with respect to posterior wall MI, though MI is discussed separately, I want to bring to your attention that for posterior wall MI, ideally we should be putting lead number V7 and V8 and V9 in the back, and then we should be identifying the leads would be put in the back, V7, V8, V9 in the posterior axillary line, the scapular line and the paravertebral line, and then we are able to identify a posterior wall MI. But in the exam, I think it was INISAT that they deliberately did not mention V7, V8, V9, and you have to identify this very classical horizontal ST depression. Horizontal ST depression with upright T wave. See, in MI you usually get a T wave inversion, but if you get horizontal ST segment depression in lead number V2 and V3 and upright T waves, then that's a feature that is suggestive of posterior wall myocardial infarction. You anyway need to put electrodes in V7, V9, but the provisional diagnosis on which the patient would be then subsequently sent to the cath lab would be a posterior wall myocardial infarction. Learning point is, posterior wall MI, ideally V7, V9, but otherwise if you get a horizontal ST segment depression, because damage is पीछे ना, anterior leads लगाएंगे तो उसमें ST depression आएगा. Current is going away from the recording electrodes. That's why ST segment depression in the CHIPS mnemonic has been mentioned at the moment. Then a T wave abnormalities, that is easy. The earliest ECG finding in MI, hyperacute T wave. Earliest ECG finding in MI is not ST elevation, it is hyperacute T wave. Tall tented T waves are found in hyperkalemia. And when it comes to a T wave inversion, then there are so many causes of it. I mean, T wave inversion is found in hypokalemia, arrow going up, hyperkalemia, arrow going down, hypokalemia, T wave inversion is also going down. Then is all varieties of anginas. Any variety of angina would ultimately cause a T wave inversion. MI of both varieties, ST non-ST, will also contribute to a T wave inversion. So like hypokalemia, angina, and MI are conditions where T wave inversion has been discussed. As far as QT interval abnormalities are concerned, I would like to just say, and I've said at beginning also, that they are inversely related to the value of calcium. So in all questions on tetany, though I've said it verbally, I'll say this at the moment in theory, that in all questions on tetany, he will always say the word QT interval prolongation. But if you read the word QTC prolongation, that is what you read with respect to TDP, that is torsatus de pointes. So do remember that chota sa c is making a word of difference. I mean, if I just say QT prolongation, that is like tetany case, but QTC is which is seen with TDP, that is torsatus de pointes. For tetany, we need to give calcium gluconate. If it is hypercalcemia, then management of hypercalcemic crisis is normal saline, and we need to give bisphosphonates for management of these patients effectively. Let's attempt a question. J wave is found in, that would be in patients of hypothermia. And the next one is also super easy. Like he gave this ECG in which the variable amplitude QRS complexes were present. So this would be answered as torsatus de pointes and not as cardiac tamponade, because in cardiac tamponade you would be having electrical alternates. One, in cardiac tamponade the ECG will be low voltage. And second, you will also notice is that the voltage will also keep on changing. Like if you check out the height of the R wave here, like I've shown normal sinus rhythm, guys. I've shown normal sinus rhythm. See, I've deliberately made it chota. Like you can see now it's more prominent. What I have done here, everything is normal, but it is the height of the RS complexes that is changing with every beat of the heart, because the heart is dancing in a bag of fluid. So what I've shown at the moment before you is two situations where variable things are present. In one, it is a normal duration QRS with variable amplitude. The normal duration QRS with variable height is electrical alternance of cardiac tamponade, but superiorly is broad. Mark my words there, guys. In tamponade, it is normal duration QRS with a variable amplitude, and in the superior diagram, it is variable amplitude QRS with a lot of guys mark that as cardiac tamponade. But in tamponade, it is normal duration QRS, guys. It's not a broad. Here you can see broad RS complexes are present in this patient with variable amplitude. So therefore, the answer for this question is given as torsatus de pointes. So I really appreciate your patience for this video, guys. It was a long one, I would say haul, but then it's all worth the effort. Thank you so much, and just keep on practicing. My suggestion is do 5 ECG questions a day. Don't do all of them together. Do 5 a day, and gradually your knowledge base will keep on expanding, and you are gonna be, doing great in your future career. So keep hammering, guys. Thank you so much.